All right. Are we live? Hello, friends. I'm Dr. Shubmohan Singh. I'm an additional professor in the Department of Psychiatry in PGI Chandigarh. PGI Chandigarh is a large tertiary hospital in North India, and I work here as a consultant in psychiatry. I also work in neuromodulation and RTMS and TDCs. And I welcome you all on behalf of the Physical Treatment Subcommittee of the Indian Psychiatric Society and the Neuromodulation Society of India to this webinar, which is the name of which is Advances in Transcranial Direct Current Stimulation in Psychiatric Disorders. I hope it will be an enriching experience for all of you. I believe we have around 450 registrants, so I expect that many people will be joining us as we go on in this program. And I wish to thank all of you who've taken out time on a weekend to join us here. Over here, we are undergoing a COVID surge, and things were a little difficult. But I'm glad that we could make it happen, and I'm glad you are here. So before we start, I would like to request Dr. Gautam Saha, who's the president of the Indian Psychiatric Society, to say a few words and to inaugurate the program.
Thank you, Dr. Shubmohan. It's really great pleasure to be here today, maybe the online, but at the outset, I must thank to the whole physical subcommittee of the Indian Psychiatric Society, starting from our chairperson, Dr. Nand Kumar, Dr. Most Active and Dynamic co-chairperson, Dr. Nand Kumar, convener, Dr. Vikash Mehta, and our advisor, Dr. Soumitra Ghosh, and EC coordinator, Dr. Bhavesh Lakhtadia. You know that today we are going to talk on the seminar on especially the advances in the transcranial direct current stimulation, TDCs. You know, in the psychiatric disorder, it is really very important nowadays. In fact, I understand the neuromodulation, if you go through in the past, it was started from the ECT and maybe the before some direct current stimulation. But after the ECT, there are lots of journey we had. And last time we have got the RTMS, repetitive transmagnetic stimulation. Already there are lots of our using this instrument, including Dr. Shubmohan. I heard his wonderful lecture by him in one conferences. And you know that after that direct current stimulation, transcranial direct current stimulation, TDCs has come. And there are evidences that there are different centers who works on it. But I think it will be a very good instrument for us. In fact, when psychiatry, people are treating that, we are just talking to them. Why medicine? Now we are using the instrument, and it is really so much gives patients relief. That is most important. And I hope in near future, maybe like TDCS, other instrument will come and will give our clients a better service. Thank you so much. Again, I thanks to the Physical Treatment Subcommittee of the Indian Psychiatric Society as well as Neuromodulation Society of India. Today, before starting the program, I want to thanks to Michelle and Nishe, Dr. Moram Biksham, Dr. Anirban Datta, and the Janardhan C. Narayan Shami, as they are the eminent speakers of today. I hope they will enlighten us on this topic. Thank you. Thank you so much.
Thank you, sir. Thank you, Dr. Gautam Saha. And today what we're going to do is that we're going to have 4 speakers. They're going to be talking on their topics one by one. We'll have Professor Nietzsche first, then Professor Bixen, Anirban Datta, and C.N. Janardhanan. All the audience are requested to type their questions on the YouTube chat box. We'll be picking up questions which are important and which are pertinent to the topic. I am also sure that that the speakers will be more than happy to kind of engage with them on email or other methods if they so desire. Professor Dixon is on Twitter, for instance. They are all active on social media. So the whole point is to learn from this exercise. We have some very distinguished speakers today. In fact, all of them are doing very, very cutting edge work. The whole idea of this program was to give the audience a taste of what is going on at the cutting edge. I also understand that TDCS is not something which is familiar to a lot of people. So I wanted that this program should have something of interest to all sorts of people with all sorts of experiences, from the absolute, the novice who has no experience with TDCS to somebody who's done a lot of work. So I'm sure it'll be interesting to all of them. I was just going through these speakers yesterday, and it is very interesting. And it is, I'm humbled to say that, the 4 speakers between them have around 100,000 citations on Google Scholar, which gives you an idea of the sort of impact that their work has had in this field. So first of all, we have Professor Michael Nietzsche. He's the scientific director in the Department of Psychology and Neurosciences in Leibniz Research Center for Working Environment and Human Factors in Dortmund, Germany. He in fact, co-authored the seminal paper with Walter Paulus in 2000 that for the first time demonstrated in humans the possibility of non-invasive modulation of motor cortex excitability by application of a weak direct current stimulation through the scalp. So he was the person who published a paper which showed that through an intact scalp, one could modulate cortical excitability by passage of a weak current. It remains one of the most cited papers. It has around 4,000 citations, more than that. And since then, he has researched and written extensively on basic and clinical research with TDCS. You can follow his work. He does a lot of interesting things. And today, and he also, I was just asking him, he's also a football fanatic, and he follows his local football team, and he used to be a player himself. I hope he can continue doing that. So today he will present an overview on new protocol developments, including dose enhancement, repetition of stimulation, as well as transferability of results from the motor to the prefrontal cortex, and furthermore, the specific impact of individual factors such as age and chronotype on stimulation aspects, on stimulation effects will also be discussed. So I welcome and I invite Professor Nietzsche to make his presentation.
Many thanks for this very kind introduction. I'm happy to be here and to present some new results in TDCS research in our laboratory we obtained in the last time. So transcranial direct stimulation is one non-invasive brain stimulation techniques which have enlarged applications relevantly during the last 20 years or so. So there are a couple of techniques available now which allow to change different aspects of physiology. We can induce activity non-invasively in the motor, but also other cortical regions with TMS. We can induce plasticity with repetitive transcranial magnetic stimulation, but also with combined peripheral and central nervous system activation via paired associative stimulation. And TDCS is another technique which allows to induce neuroplasticity, which means lasting alterations of cortical excitability and activity, as you can see here for an example of a TMS protocol, where you can see with repetitive TMS, dependent on the specific protocol, you can enhance excitability, the amplitude of motor evoked potentials when you stimulate the motor cortex, or you can reduce excitability, and these effects can last longer than the stimulation itself. Plasticity is an important physiological mechanism of the brain, for example, of primary importance for learning, memory formation, and related stuff. You can also modulate oscillatory activity nowadays with transcranial stimulation techniques, for example, with transcranial alternating current stimulation, which is a kind of derivative of TDCS, which works also with relatively low stimulation intensities. So a principal mechanism of TDCS on neurons is that depending on the polarity or on the electrical field direction and directionality of a neuron, it can de- or hyperpolarize resting membrane potentials at a subthreshold level. So it doesn't induce action potentials, but makes the induction of action potential is more or less probable, dependent on the alteration of resting membrane potential. For example, if you put it nearer to the depolarization threshold, you need less incoming activity to induce activity of your target neuron. You can see here that we are doing this since quite a while. Standard protocol was with which we started relatively large electrodes. We did here targets the primary motor cortex. We have a return electrode here over the orbital area. You can see also that it's not really rocket science. We stimulate with low intensities, which are not painful. So with these electrodes, intensity of 1 to 3 milliamp, for example. And this explains also why we don't induce super threshold activation of neurons, where you would need a much higher stimulation intensity. If you stimulate for a few minutes, you don't get only active effects on acute effects on membrane polarization. You get also neuroplastic effects. You can see this here by 2 studies. When we put the anode over the primary motor cortex, we get an enhancement of motor evoked potential, so an increase of motor cortex excitability, which, dependent on the stimulation duration, can last for an hour or a bit longer after the end of stimulation. When you switch polarity of the stimulation electrode, then you get an excitability diminution, what you can see here. And this depends also on the duration of stimulation. So 5-minute stimulation results in short-lasting effects. Here is 9-minute stimulation. We get the 60 minutes excitability diminution with cathode TDCs over the motor cortex. Okay, so these are the principal effects we have shown already now 15 years ago. However, of course, important open questions. So one question is if all effects are linear, and recent studies have shown that they are not. Another question is, are the same, do you get everywhere the same effects, so in different cortical areas in any conditions? And another question is, how can we optimize stimulation protocols to get what is especially important for clinical application, to get maximally strong effects and clinically relevant effects of stimulation. For discussing this, and also some nonlinear effects of TDCs, it's important to know a bit more about basic physiological mechanisms. And one common plasticity mechanism in cortical areas is that plasticity is driven by primarily glutamatergic synapses and is calcium dependent. So dependent on the activity of a presynaptic neuron, you will have activation of glutamatergic receptors. These are NMDA receptors, AMPA receptors. NMDA receptors need some kind of massive activation of massive glutamate release to become activated. And NMDA receptors work as calcium channels. And what is known then also is that, dependent on the calcium concentration in the postsynaptic neuron, you will have a removal or insertion of AMPA receptors to or from the subsynaptic membrane. High calcium concentrations result in an insertion of AMPA receptors, low calcium concentrations in removal of AMPA receptors. And I can imagine that this insertion or removal of AMPA receptors strengthens or weakens synaptic membranes. And it has so if you have high calcium concentration, you have a strengthening of the synaptic connection. If you have low calcium, then we have a weakening of the synaptic connection. And we tested if this calcium dependency and this glutamate dependency is also valid for TDCS-induced after effects. And here one study with an NMDA receptor blocker, this is dextromethorphan, you can see as compared to a sham, to a sham medication. Under dextromethorphan, there was no plasticity apparent anymore. So what we showed here is that TDCS-induced plasticity depend on NMDA receptors. And when we block calcium channels with flunarizine, we can see also an important impact on TDCS-induced plasticity. So here under sham medication, placebo medication, you can see the normal neuroplastic effects of anodal TDCS. When we block calcium channels with flunarizine, you can see that these effects are no longer present. So the effects of TDCS the plastic effects of TDCS depend on glutamate and calcium concentration. With respect to the dependency of plasticity from calcium concentration, I told you already that low calcium concentration or low calcium enhancement results in excitability diminishing plasticity or long-term depression, whereas high calcium concentration results in long-term potentiation. You have a transition zone between these both kinds of plasticity with medium calcium amounts, and you have where you don't see any resulting plasticity, and you have also a region where you have a calcium overflow, where antagonistic mechanisms apply, where you don't get long-term potentiation anymore. So you have these calcium dependency, and this has consequences also for the efficacy of TDCS. So since with higher calcium concentration within a certain concentration range, you get stronger plasticities, and this should mean also that when you intensify TDCS, you get stronger plasticity with TDCS within the certain ranges. And we have shown this, so also in our first study, that when we stimulated for 5 minutes between 0.2 and 1 milliamp, with stronger stimulation, we got better effects. And when we stimulated with 1 milliamp between 1 and 5 minutes, longer stimulation resulted also in better effects of the stimulation. So this calcium concentration dependency of the efficacy of stimulation within certain windows of stimulation works well. But we could also show that when stimulation exceeded these windows, so we did here 30 minutes anodal TDCS and here 26 minutes anodal TDCS, and we get nonlinear effects. So here's a switch of anodal TDCS after effects from excitability enhancement to an excitability diminution. We thought this might be due to calcium overflow. So with 13 minutes, we might be in this range, with 26 minutes stimulation in this no man's land too. And we tested this hypothesis via blocking calcium channels again with flunarizine. And you can see, as compared to the placebo medication condition, you see here that the excitability diminution with 26 minutes stimulation is under flunarizine. It's converted again. So this shows that calcium overflow is the most probable mechanism inducing these nonlinear effects. Having said this, then of course it's interesting to identify stimulation duration, stimulation intensity ranges which induce strong but not the conversion of effects, so not nonlinear effects. And I want to show you here some studies we conducted where we systematically titrated different stimulation intensities and durations between 15 and 30 minutes, stimulation intensity between 1 and 3 milliamp, and also did repetitive stimulation to see if we could intensify the efficacy of TDCS with these protocols. That's a study here was anodal TDCS, where we stimulated between 1 and 3 milliamp for 15 to 30 minutes. Healthy young subjects, stimulation over the motor cortex. And you can see here that with all of these stimulation intensities and duration combination, we get excitability enhancements via the stimulation. It's a study conducted by Desmond Akwauda in our laboratory. But you can also see that there's a gradual increase of the efficacy of stimulation if you look at the amplitude of the effects, but also at the stability of these effects with 3 milliamp stimulation as compared to the other stimulation intensities. So we get within this range of 1 to 3 milliamp and 15 to 30 minutes stimulation relatively stable effects of the stimulation. Desmond did then another study where we did repeated stimulation, so 2 times stimulation with different interstimulation intervals for the optimized protocol with 3 milliamp stimulation 20 minutes and standard protocol 1 milliamp 15 minutes stimulation. We had intervals of 20 minutes and 3 hours because it's known to induce late phase plasticity in animal experiments, but we have shown this before also in humans. You need to repeat stimulation with relatively short intervals. Within a time window of 30 minutes, you get a potentiation of the effects, which effects of single stimulation normally last for an hour or a bit longer. But there it was shown in animal experiments, but also in humans. It was these short intervals, you get effects lasting for over 24 hours, sometimes for days and so on, and induce also structural plasticity. We did the control condition with 3 hours interstimulation interval, where we are outside this window, and expected here as a control condition that we don't get these late phase effects of the stimulation. And what you can see here indeed is that for the single stimulation conditions, you get an excitability enhancement lasting roughly 30 minutes to 1 hour. As these short intervals, you get a prolongation of the effects, and interestingly, we got late phase plasticity only with a lower stimulation intensity, not with a higher stimulation intensity. And for the long interval epochs, we get with a lower stimulation intensity a trend-wise recovery of plasticity, but we don't see this with a higher stimulation intensity. So this shows that repetitive stimulation is principally suited to induce really long-lasting effects if you use specific interstimulation intervals, but that there's a nonlinear effect of stimulation intensity, so not the stronger stimulation gives us a better long-term effects here. Okay, we did similar studies with cathode stimulation, so with excitability stimulation, reducing stimulation over the primary motor cortex, so identical stimulation intensities and durations. Here the effects are a bit different. You can see here that with 1 milliamp, with 1 milliamp stimulation for all stimulation durations, you get an excitability diminution. You get this also with 3 milliamp stimulation, but with 2 milliamp stimulation, we get an excitability enhancement. If you think back about this calcium dependency, you could speculate that with this higher intensity, you get in the calcium range, which induces LTP-like plasticity, no longer LTD-like plasticity. The question is what happens here then with the even higher intensity. Because and what could happen here is that you are in the calcium overflow range, and because of this, you get this excitability diminution again. This was a study conducted by Mohsen Musayebi in our laboratory, and we explored these inhibitory effects, 3 milliamp stimulation and the calcium dependency, via application of different dosages of flunarizine between 2.5 to 10 milligrams. And what you can see here for this high intensity stimulation is that this inhibition flips back into an excitability enhancement. So if you were in the second no man's land of calcium overflow, we reduce calcium, then we are getting here back into the LTP, long-term potentiation-like plasticity inducing range. So what we get with 3 milliamp is kind of secondary inhibition, most likely caused by calcium overflow. Mohsen did also a study with repeated stimulation, identical to the protocol I showed you for anode TDCs. So here we compared standard stimulation protocol with enhanced stimulation protocol that again short and long interstimulation intervals. You can see here the inhibition excitability diminution with the standard protocol. Here with short interval and then also with long intervals. And so in difference to anode TDCs, we didn't see a prolongation of the after effects of cathode TDCs here. One reason might be that it was shown in animal experiments that to get long-lasting, long-term depression-like plasticity, you have not only to repeat stimulation once within certain intervals, but have to repeat this more often, and that's a study we will conduct in future. Okay, so for the first part, I've shown you that there are dosage-dependent TDCs effects, which are not linear in each case. Extending TDCs beyond 1 milliampere and 50-minute stimulation can gradually improve efficiency. Repetition of stimulation within specific intervals induces late-phase plasticity for anode, but not for cathode TDCs. Next important question is, do the effects of TDCs transfer from the motor cortex? So these were all motor cortex experiments also to other areas. And there are early studies, one of Andrea Antal for the visual cortex, and one here from Matsunaga for the somatosensory cortex, which show at least principal qualitative transferability. So when you stimulate the visual cortex, you get excitability diminution with cathode TDCS and excitability enhancement with anode TDCS, but TDCS of 1 milliamp intensity seems to be a bit less efficient as compared to the primary motor cortex. For the somatosensory cortex, you get a nice excitability enhancement here with anode TDCS. No effect in the resting somatosensory cortex with cathode TDCS. So there's also gradual difference of these effects. You were interested if we could transfer the physiological effects of TDCS we achieve in the motor cortex to the dorsolateral prefrontal cortex, and used TMS-EG as readout measures. So we applied TMS over the dorsolateral prefrontal cortex, which induces activity in this area, and you get cortical evoked potentials, which you can measure with the EEG here. Then we did TDCS. We did as a control condition, we did it not only over the dorsolateral prefrontal cortex, but also all over the primary motor cortex. Then again, we monitored after the intervention, we monitored the effects of the stimulation on cortical activity, cortical excitability obtained by TDCS. So this is how these potentials look like. And we got them in the primary motor cortex with early potentials and with late potentials, and quite similar potentials also in the dorsolateral prefrontal cortex. It's again a study conducted by Desmond Akbuada. We showed similar effects on motor evoked potentials as we got them in previous experiments. So no effects with sham stimulation, but MEPs were enhanced with different dosages of TDCS, and these effects lasted for about 1 hour or a bit longer after the stimulation, dependent on dosage. And then we looked for the effects on these cortical evoked potentials. And here on the right side is the primary, left side is the primary motor cortex. On the right side are the prefrontal cortex effects. And you can see here that for the first P30 positive wave, which depends on glutamatergic activity, there is an enhancement of excitability you see in the motor cortex and also in the prefrontal cortex. The effects on GABA seem not to be very strong with the N45. We don't see strong effects on the motor cortex, and also not strong effects on the dorsolateral prefrontal cortex. If you see anything, then it's indicative for reduction of GABA activity, which is also shown in other studies that GABA is reduced by TDCS. And we get with the P60, which is controlled by the glutamatergic and GABAergic system, you see again an excitability enhancement here. So this shows that there is a transferability, a general transferability of anode TDCS effects between primary motor and dorsolateral prefrontal cortex. Desmond Mozayebi did the same thing for cathode TDCS. So also stimulation with TDCS over the primary motor cortex, over the DLPFC, with different stimulation intensities. You can see here for the MEPs, you see again this non-linearity, with excitability enhancement, with medium dosage TDCS. When you compare here motor cortex with dorsolateral prefrontal cortex, stimulation results on TMS evoked cortical potentials, you can see that the effects for the low dosage and for the high dosages for the P30 are relatively similar between both areas. Interestingly, we don't see the switch of excitability to enhancement in the prefrontal cortex. We only see this in the primary motor cortex. Again, no large effect N45. For this combined glutamatergic GABA P60, you can see again an excitability diminution here, which is quite similar between the primary motor cortex and the dorsolateral prefrontal cortex. So also for cathode stimulation, we get grossly a transferability between of TDCS effects between primary motor cortex and the dorsal or prefrontal cortex. So after effects are principally comparable between these areas. Effects might be gradually smaller in the prefrontal cortex, so higher stimulation intensity might be better suited at the end. And in the prefrontal cortex, that's an important aspect. We don't see these nonlinear effects of cathode TDCS with the given dosages. Might be due to different electric fields, but what is also an important aspect is that neurotransmitters and synapses are a bit different distributions and availability a bit different between these cortical areas. Okay, at the end, I want to show you some effects about individual modulators of plasticity. So personalization of non-invasive brain stimulation became a big topic in recent years. And it's important for adaptation of stimulation to know something of factors which are important modulators of the efficacy of TDCS. This is a study here conducted by Ensi, Gashemi, and Shirvan, where we explored the efficacy of TDCS over the primary motor cortex on adults of different age groups, so young adults and then adults at the age of 55 to 65 and over 65 years old. We did 1 milliamp stimulation for 30 minutes. And what you can see here is that for analog TDCS, there's a gradual decline of TDCS-induced long-term potentiation like plasticity. These are the young subjects, these are the young old ones, and these are the old ones. And you can see in this 1 milliamp, there's a decline of the induced plasticity. You see this for analog TDCS, we don't see this for cathode TDCS. The induced plasticity is quite similar. For sham stimulation, MEPs didn't change over time. So this shows that the propensity to develop long-term potentiation induced by TDCS is reduced in higher age. This does, however, not mean that you can't induce long-term potentiation like plasticity by TDCS in older people. Later, Farnat did a study where we did the same stimulation protocols as I've shown you before for young people, now in older age group, young, old, and old age group. And you can see here that over all conditions, there's still an excitability enhancement via analog TDCS, which is again here larger for the higher intensity conditions. So it depends on the specific stimulation protocols if you induce plasticity also in old people or if you are not able to induce plasticity. Okay, the next and last neuromodulator modulator of TDCS effects I want to show you now, and this is the effect of chronotype. So you all know that there are some people who are very awake and very alert in the early mornings when they wake up, and some are not, and most of these are functioning better in late hours of the day. And that's a genetically driven difference between people, which is also known to involve cognitive performance. So some are great in the morning, some are better in the evening. And we were interested to explore if these morningness or eveningness types are also relevant for the induction of neuroplasticity. I want to show you just a part of these results here. So we had a group of early and late chronotypes, and what we could show is that for the early chronotypes, where we did plasticity induction in the morning with TDCS, they had a high amount of long-term potentiation-like and a high amount of long-term depression-like plasticity in the morning. So these are the people who like to get up early. And in the evening, they had a decreased amount of plasticity induced by the same stimulation protocol. Interestingly, in the late chronotypes, the situation was antagonistic, was completely different. You can see here they have reduced plasticity in the morning in both directions, but enhanced plasticity in the evening, where we induce plasticity at 7 p.m. in the evening. So there's a chronotype dependent difference between inducibility of plasticity. And this is also shown for motor learning. You can see here for the early chronotypes, this was a sequence motor learning task. Reaction time is the readout, and the lower reaction time indicates better performance. You can see the early chronotypes are better with motor learning in the morning. The evening chronotypes are better in later hours of the day. And that's, of course, also of potential practical importance if you think about rehabilitation, for example. If you do this with a late chronotype in the morning, you might have much worse effects than with an early chronotype when you conduct the same interventions in the morning. So this might mean something for practical application. So individual characteristics affect plasticity response to TDCS. Higher age reduces LTP-like plasticity, but not LTD-like plasticity. Plasticity can, however, still be induced by TDCS, and chronotype might be an important individual factor which determines the size of plasticity and the amount of learning at specific daytimes. Okay, so systematic dosing of stimulation parameters revealed partially superior effects of intensified TDCS protocols. This was what I've shown you in the first part. And what I've shown in the second part is that individual characteristics such as age and chronotype affect the plasticity response and should be taken into consideration also in later studies. So many thanks for your attention, and I'm open for questions now.
All right. Thank you, Dr. Nietzsche. That was a wonderful talk. I was really spellbound because I was listening to all of this very carefully. I'll just summarize it for the people that it was all about, showing that TDCS leads to demonstrable changes in neuronal activity. This is usually calcium dependent. This is non-linear in the sense that there are specific parameters which lead to higher, excitability or the reverse. It's usually what you do over there is basically look at the M1 or the motor cortex, but these changes are also kind of, you can translate them into the prefrontal cortex activity, which is what is important from a psychological point of view, because that's where most of the higher cognitive activity is going on. And also there are modulators of TDCS. Basically, what I think that implies is that you could probably classify your clients or your patients as per specific biological parameters, and that would basically predict what kind of benefit or what kind of response that they might have to a particular protocol. So one can sort of tailor a specific protocol to a specific individual or a specific person. We have a few questions here which have been texted to me by some people. So in fact, we were looking at, I think what Professor Nietzsche talked about right now as a lot of clinical relevance also, because one of the major problems that we face in TDCS is the fact that it is usually clinic delivered. It is delivered in a hospital, and most of the times it requires many sessions. Most of the times in our clinical setting, we give maybe 1 or 2 sessions every day. That's especially true for conventional TDCS. So what I would like to ask is that, is your research going to lead to shorter protocols where you could probably do with maybe 1 or 2 sessions over a period of time, maybe assisted by some plasticity enhancers, which can lead to shorter protocols where you don't need to have the patient with you for weeks or something like that. This is a main problem that we have with TMS and TDCS, because they take a fairly long time.
Understand. So we have some extended protocol for RTMS, if you think about TBS and so on. But so to shorten it, I mean, this has 2 sides. So for clinical application, you want to have really long-term effects, and it's also known from RTMS studies For example, for depression treatments, they needed 6 weeks or so to get significant effects, which also makes sense because they have a dysfunctional plasticity, and to reverse this and to change synaptic strength within a very short time course, this might be problematic. So this is all neuromodulation, and it needs some times. Similar also for the medication, of course. What might help is, so I showed this repeated protocols where we get late phase plasticity with repeated stimulation with short intervals. And so for single stimulation once per day, every 24 hours, this might not be optimal because the single stimulation normally gets you early phase plasticity, which vanishes within few hours. I'm relatively optimistic that with these repeated protocols within relatively short times, you might get higher efficiency within shortened timelines. But if you, of course, one problematic aspect is to get patients always into the hospital. I think what Marom might talk about also is about home use devices, which might make situations in future a bit easier. But one stimulation, so let's say I do it one day, and then you get plastic effects which last for weeks, months or so. That's something I think there's no intervention available at brain stimulation or not, which guarantees this now. And this might be due to the physiology of plasticity.
We'll take that later. Yeah. Another question that came to me was, all right. Yeah, Janardhanan has a question. Can we just take that? Yeah, what might be an ideal time gap between sessions for better adaptive plasticity change?
Yeah.
So is that like same for all people, or is it different? So can we in any way predict what would do better in a certain individual?
So for the induction of late phase plasticity, and this is what you want to get at the end, so stability of plasticity. There's derived from animal experiments, but based our experiments on this also. The optimal interval is within a time window of 30 minutes. So, and there are some studies, also clinical studies. I remember one addiction studies from Brazilian group we are collaborating with, as I did 2 times 30 minutes stimulation with a 20 minutes interval. It did it not only on one day, but on consecutive days, and got relatively impressive effects. What we would need now, I think, is also face-to-face comparisons between standard protocols and these repeated stimulation protocols. At this 30 minutes time window, as I said, has been shown in animal experiments. It's known why there is this window and why this works. And I think that's at least a strong candidate.
Just one last question before we let you go for the moment. Is that, regarding plasticity, what is the metric of plasticity that you have in the sense? You spoke about plasticity, but in a lab, for instance, how do you demonstrate plasticity?
Yeah, so when we stimulate the motor cortex, then the standard measure of plasticity is the change of the amplitude of motor evoked potential amplitudes we induce with TMS. So you can look at plasticities, and you do at excitability changes. When you do time courses, then you can talk about plasticity when you see these alterations lasting for certain time after the end of your intervention. For the prefrontal cortex, I've shown these studies with cortical evoked potentials. So that's also a measure of excitability. And if you want to talk about plasticity, then the duration of the effects is always important, of course. But these are standard measures. You can use fMRI, can use also EEG, but these are all more complex readouts, which are, for example, for fMRI, this is not only both and also ASL, not only affected by neuronal activity alterations, but also by direct effect on vessels. So it's a bit more tricky to interpret.
Thank you, Professor Nietzsche. Thank you for your talk. And we'll have you back after some time. Absolutely. And now I'd like to introduce Professor Bixen, He's from the Department of Biomedical Engineering, the City College of New York, USA. His areas of expertise and research include biomedical engineering, medical devices, electrical safety, brain function, and disease. He's also the founder and CEO of Sotrix. We use Sotrix devices in our department as well. Sotrix is one of the leaders in TDCs technology, as we all know. And he's a prolific author. He works on a variety of neurocognitive phenomena and TDCs. I always enjoy reading his papers, and we are very glad that he's there. And today he'll be talking about best practices and latest developments in TDCs.
Thank you. Thank you very much for that introduction. I hope you can see my slides, yes?
No.
No. Oh, I'll try again, I'm sorry.
Yes.
Great. Again, thank you very much for the opportunity and the invitation to speak today. It is really also an honor to just follow up on Michael Nietzsche, who, as you already mentioned, is really one of the co-founders of TDCs as a modern field. And so it also makes it a little bit easier for me to give this talk because he's already done a wonderful job of laying the foundations. And so I can use my talk to sort of focus on highlights of topics I think would be of general interest, as you said in your introduction, both to new users and to experienced users. Okay. So these are my conflicts, and I have already put the slides online for people who are interested in them at this Twitter account. Just a few words about neuromodulation in general. There are different neuromodulation techniques out there that would be familiar maybe to this audience, ranging from invasive techniques that require surgery, like deep brain stimulation or spinal cord stimulation, to non-invasive techniques like TMS, and we also heard ECT is one of the earliest forms or an early form of neuromodulation. And then we have the topic that we're focusing on today, which is transcranial electrical stimulation and transcranial direct current stimulation. And I just want to point out that, while some of these are implants and so they inherently require surgery, others, because of the complexity of the devices or the intervention, necessarily require visits to a hospital or to a medical center. Well, we have another class of technologies, what we're focusing on here, which, to use a trendy word, I can call wearable. And they include transcranial direct current stimulation, and they can be used in very diverse care centers, as well as potentially at home. And I'll talk a little bit about that. And so that's the focus today. We already heard a great introduction from Dr. Nietzsche, so I don't need to say too much. Transcranial direct current stimulation is a technology where current is applied to the brain, but it's applied non-invasively. So using electrodes on the scalp, the current is passed from an anode to a cathode. And again, one thing that's very peculiar about TDCs compared to other neuromodulation techniques out there is that it uses a sustained direct current. Almost every other form of neuromodulation uses pulses. But what's particular here is that it's ongoing and it's sustained. So that is sort of a defining waveform characteristic. It's the direct current in the transcranial direct current stimulation, and it is extensively investigated. And I possibly one of the most, if not the most broadly investigated interventional neurotechnology. So this is what it looks like on my head. Again, there are always two electrodes. There must be two electrodes. Those are the pink things you're seeing there. One electrode we refer to as the anode, and the other electrode referred to as the cathode. The wires going down my neck there would be connected to a stimulator, which is much more advanced than a 9-volt battery. But it's nice to show a 9-volt battery to emphasize that this is a direct sustained current. And it's a current controlled stimulation. So typically a few milliamps of stimulation for about 20 minutes. Again, you will hear the terms anodal and cathodal stimulation used. And I think it's important to remember there's always an anode and a cathode. There's no just anodal without the cathodal. So what anodal stimulation actually means is that the target of interest, the brain region of interest, is near the anode. While cathodal stimulation means that the primary region of interest is near the cathode. that's the area we hope to influence. So that is the meaning of a nodal and cathodal stimulation. And this is a very well tolerated technique. Dr. Nietzsche already explained. Really, the main side effects we're looking at is itching, a little bit of redness. And so this has really accelerated and supported the broad deployment of the technique. Just a few words on mechanism to build on what's already been said. Here we have a cartoon of the head. There you have the anode and the cathode electrode. Under the anode, the current is flowing into the head, so it's arriving at the cortex. Well, at the cathode, it's flowing out of the brain, so it's exiting the cortex. And it's been known for a very long time that as this current flows through the cortex, it will polarize the cells in the cortex. It will change their membrane potential. And it's very well known that it does this in a current-specific, direction-specific manner. So that under the anode, this is a cartoon, but this is a cortical pyramidal neuron with a large apical dendrite pointed to the surface. Under the anode, where current flows into the head, so into the cortex, we will produce a somatic depolarization. And this is thought to underlie a lot of the increases in excitability that are reported. Under the cathode, you have the same intensity of current, but it is in the opposite direction. It is exiting the head. It is exiting the cortex. And because of that flip in current flow direction, the polarization that is produced on the neurons also flips. And so under cathodal TDCS, we have a somatic hyperpolarization. And this is thought to underlie many of the inhibitory effects. And again, this is a very well established, even though I would say the effects of TDCS are not trivial, and we just heard about that. This particular aspect of stimulation, I think, is very well established. Now, for a while now, we've been using current flow models, MRI-derived current flow models through the head to better understand how this current flow actually gets into the head. This is obviously just a cartoon, but maybe we can be more precise here. So these are MRI-derived models. So starting with a high-resolution scan of someone's head, we then create a 3D volume that represents different tissues that are between the electrode and the brain, and we represent the brain as well. So you see scalp, bone, CSF, and so on. And what we can do with these computational models is we can simulate placing electrodes on different parts of the head, and in more detail, predict where current flows through the head, which brain regions get current flow, which don't, and also how much current flow gets into the brain. So these can be also individualized. And we and others have been doing this now for over a decade. This is an example of one kind of simulation. So here's a subject's head. This is the M1 SO montage. We've heard a little bit about that in the last talk, or a lot, I would say. These are large 5x7 pads, and we have the different tissues represented, and current is going to be simulated as it flows through the entire head. But I'm going to be showing you current flow specifically on the surface of the brain, because that's the target we're interested in. And when we show current intensity across the surface of the brain in these models, we use a false color map, where often hotter colors indicate an area that gets more current intensity, while cooler colors might show an area that does not get current flow intensity. So this is the result of one of our earliest stimulations, the first, in fact, gyri-specific simulation. And this is showing the current produced by the M1 SO montage. So one electrode is over the motor cortex and one is over the supraorbital region. And what you're seeing is a lot of red and not so much black. And the reason is that in this particular montage, the models predict that you will have a rather diffuse current flow flowing through much of the head. And that moreover, you'll get these hot spots. You see these little yellow hot spots, and these hot spots are not necessarily under the electrodes themselves. And you can see in these cross-sectional plots on the bottom left that the current flow is also flowing and rather deep. So transcranial direct current stimulation under conventional montages doesn't just produce current in the superficial cortex, but can easily drive current into deep brain regions. And these computational models have been enhanced in many ways over the past decade, and they've also been repeatedly validated using different experimental techniques. Now, in the same study, we suggested that instead of using large electrodes, you might be able to use small electrodes that we went on to call high definition electrodes. Because these electrodes are smaller, you can put more of them on the head. I'm showing you here 5. You could put 32. You could put them closer to one another, and you can control which ones are anodes and which ones are cathodes. So in this example here, the red one is the anode, and the 4 electrodes are the cathodes. And what we showed in computational models first, and later validated in experiments, is that when you stimulate it in this way, you could produce focal patterns of current flow through the head. So this would be the 4x1, 4x1, a high definition montage. And you can see here in a computer simulation, focal stimulation of regions around the motor cortex. And again, this computational model has been extensively validated since its inception. But the point is that it's important to recognize that with non-invasive electrical stimulation, you can be focal. In this case, I'm showing you a situation where on the right side, the center electrode is the anode and the outers are the cathode. While in the other simulation, the center electrode is the cathode and the outside are the anodes. And what these false color maps show here is red shows regions of inward current flow, while blue shows regions of outward current flow. And so by selecting the polarity of the middle electrode, whether the middle is an anode or is a cathode, you can produce a largely unidirectional pattern of current flow, obviously with more subtlety than I'm summarizing here briefly. Now, as far as what this current flow does, I want to say that there has been a lot of data showing that in addition to producing this polarization that I showed you earlier, direct current stimulation is a powerful modulator of plasticity. Dr. Niche showed extensive data with clinical neurophysiology. A lot of my work has been focused on animal studies. And you are not supposed to be able to see everything that I'm showing here. And that's almost on purpose. My point is that there have been dozens of studies, each study with a dozen figures unpacking this topic. It is simply very well established that direct current stimulation produces plasticity, but more than that, there's been tremendous nuance on how this plasticity is induced, the types of plasticity that is produced. And so really I'm referring here to the animal literature, while Dr. Nietzsche has shown you extensive data on the human literature. So I think I just want to really ground us in the fact that we know very well at a cellular level, we have very good ideas of how direct current stimulation is working. And one of the strongest findings we have is that if you have ongoing brain plasticity and you put direct current stimulation on top of it, you can boost it. And again, I will refer you to this paper and 30 references within this paper to solidify this notion. But in the time I have, I wanted to focus on a couple newer ideas. One of them, which I think we alluded to in the last Q&A, has to do with going home with TDCS, home-based TDCS. I think is a very interesting topic. I think the current pandemic situation, unfortunately, has accelerated the pressure to consider how much we can deploy neuromodulation techniques at home. And as I mentioned, unlike other techniques like repetitive transcranial magnetic stimulation, TDCS can go home in principle. These are some examples of some home use technologies, not just direct current stimulation, but there's other non-invasive techniques like auricular vagus nerve stimulation that are being deployed home. And in my own work, we've really focused on this idea of remote supervised neuromodulation. This is not an individual who might get a device on their own and self-prescribe stimulation. What we're really talking about when we're talking about remote supervised neuromodulation or remote supervised TDCS, is what we're talking about is a rigorous application of TDCS or other techniques at a home setting under control and supervision of a researcher or doctor. So it's essentially entirely under prescription or entirely under a rigorous research protocol. And we and others have been thinking a lot about how to systemize this. And this is where this principle of remote supervised comes in. This paper here is a guidance document that really lists a punch list of all the things that need to be done to ensure that remote supervised neuromodulation is done in a rigorous way. And I don't think it's a difficult list, but it is a checklist of things you need to go through, such as you need to certify that the individual who is applying TDCS at home can do it. right? That would be one of the things on the checklist. You must train them and you must explicitly certify, right? You can't just based on trust that they can do it on their own. So that'd be one example of items that you need to do on the checklist. Another item on the checklist would be you must continuously monitor their compliance, right? And you must continuously monitor for adverse effects, and you must have the ability to remotely stop stimulation, right? So it's as soon as the user becomes divorced from the doctor or the researcher, the devices are bricked. They become inoperable because now you have broken the remote supervised rubric. Now, how you would implement this is very trial specific. We're very vague. Rather, we set up principles that should be followed. And again, with the COVID pandemic, massive disruption of research activities across the world, the pressure for this accelerated, and we collaborated with a large group of international authors to try to give guidelines for how to continue clinical services and research through the pandemic. And I'll tell you, for all the disruption, those centers and labs that were doing remote TDCS either did it or they started to do it. Their activities actually accelerated through the pandemic. They were not slowed down at all. When we think about going from home, between the home use and the medical center, obviously in addition to having specialized equipment at the medical center, you have the experts themselves, right? And as you go to more tertiary clinics, all the home use, you lose the level of expertise, right? Obviously a home user, it may not have a priori may not have any training at all, or their caregiver may not give it. And so the way we balance this is we make sure that as we go from the medical center to the home use, we have increased automation. Whereas the device in the medical center may have tremendous flexibility, 30 frequencies, 90 intensities, 100 montages, right? All the flexibility that we want in our devices, that flexibility maybe should be removed as you move towards these secondary clinics over the home, such as maybe the home device should only have one setting, right? The setting that it has been pre-programmed to do, and only one headgear placement. And so for this reason, it's important, I want to make the point that the devices that are very well suited and optimized for use at a medical center may not be suited for home use. A device that is 100% reproducible and a great piece of equipment to use at a research center is not necessarily the same device that you should give an individual to take home because of this concern, right? And so overall, in this remote supervised rubric, we're really talking about risk, and we say, well, is more risk acceptable in the home case? No, it's not. And the way we can manage risk, the way we can keep risk flat, the way we can keep reproducibility flat is by doing things like following these remote supervised rubrics and making sure that we use the right equipment in the right space. Another area that I'm just going to mention, but I think it's so interesting, is also the enhancement of monitoring at home. So just like we have increased stimulation techniques at home, we have more and more ways to monitor. Obviously, we have telemedicine, we have remote visits, and that is part of it. That is part of remote therapy. But we also increasingly have technologies that are designed to monitor brain function at home. And I think that that's very exciting. So now we're not just doing the interventions at home, we're doing the monitoring at home. Obviously, there are technological costs and issues with it, but I think this is a good frontier. I'll mention two trials that are currently ongoing that I'm very enthusiastic about that are embracing this idea. One is a large FDA IDE trial in the US looking at transcranial direct current stimulation for depression. This was motivated largely by the fact that, especially at the height of the pandemic, and I'm based in New York City, it like in many places, it got very bad here. Many patients couldn't go in to see their doctor, and so things like repetitive TMS or electroconvulsive therapy became inaccessible to these patients, right? And so there's this pressure to say, well, can we provide them a substitute? That was part of the reason why this trial was initiated. This is a 100% contactless trial. There is not a single requirement for the patient to come into the hospital. They are recruited remotely via the website. This is a trial, they are consented remotely. They are screened remotely by a medical team. There's a process then to ship them a box with all the equipment that they need. There's a process to unpack the box, to train them, all the assessments, everything else. is done remotely, either automatically by the software and so on. And again, this is all under the remote supervised rubric. There's no independent use of the device. Once the trial is complete, the device becomes inactive and it's sent back. And this, like many remote supervised trials, lends itself to being scaled very quickly. It's being run through the NYU, New York University, Langone Medical Center, but it's actually across the United States, because with remote supervised, in this kind of sense, there's no real sense of boundaries, right? The person can be very far away. They don't necessarily have to be local the way you would force them to be with a traditional trial. Another effort I really wanted to mention that I'm very enthusiastic about is using transcranial auricular vagus nerve stimulation. I briefly mentioned this when introduced other forms of neuromodulation. This is stimulation that's applied via the ear. I know it is not a focus of the effort today, but I wanted to mention this trial because it is looking at post-COVID symptoms. By some indications, 1/3 of individuals who have an acute COVID infection go on to experience emergent neurological or psychiatric issues. We don't fully understand the scale of this just yet, I think because we're too busy dealing with the immediate repercussions. But we all know this. We all know this personally because we know people who have experienced this, and of course, anyone who's working at a medical center is aware of this. So this trial is specifically dealing with these emergent neurological and psychiatric symptoms. The intervention in this case is not TDCS, it's TAVNS, but again, it's 100% contactless. There's no physical interaction at all. There's not a single visit to the medical center. But there's not just a lot of stimulation, but as I mentioned here, there's a lot of monitoring. So there's remote oximetry and other physiological monitors, extensive telemedicine visits. And so it's not simply just giving someone a device and sending them home. That's absolutely not the remote supervised idea. It's about intensive interaction, even when you're at home. The last thing I want to talk about is something that I'm really excited about. It's a new mechanism, or well, everything old is new, but it's an emergent idea in neuromodulation that I'm calling neurovascular modulation, and it changes a lot about how we think about neuromodulation, as I'll explain. It also suggests new therapeutic pathways, and I'll talk about that as well. But first, let me introduce the idea of neurovascular modulation, and specifically the hypothesis that transcranial direct current stimulation has direct effects on brain vasculature. So everything we talked about before, right? We had TDCS and we had neurons, right? TDCS, neurons, and then we had plasticity of the neurons. This idea is different. The brain, of course, is intensely riddled with blood vessels of different sizes down to capillaries. And the notion is that the direct current stimulation is stimulating the blood supply. It is stimulating the capillaries and the large vessels as well. The most obvious adverse effect, what they call adverse effect of TDCS, is skin reddening, right? There's intense reddening under the electrode, and it is related to the current flow, not just to the pressure. So if the skin is reddening, could the brain be reddening? And if the brain is reddening, what are the implications of that for neuromodulation? So this is just a brief introduction to sort of the capillary, the vascular structure of the brain. The brain, it's amazing to me, the density of blood vessels in the brain. The average distance between capillaries is about 50 microns. So you're basically talking about blood vessel, neuron, blood vessel, neuron. That's average, is 50 microns at the smallest scale. And the division between the blood and the brain is called the blood-brain barrier. These are the walls of the capillaries. It's an incredibly tight barrier, and it's an incredibly well-regulated barrier, because what's in the blood should stay in the blood, and what is around the neurons should stay in the neurons. And obviously, if this barrier breaks down, the results can be catastrophic. And so it's a very, very tight, regulated barrier, and the functions of that barrier are very important. But it's not a static barrier. It changes. Blood supply changes, right? And the transport across the blood-brain barrier also very changes. And this is typically what people call neurovascular coupling, where the neurons put demands on the blood supply. A brain region becomes more active, and it activates a secondary change in vascular supply. So this is neurovascular coupling. Neurons first, vascular second. And people will also talk about the neurovascular unit. And this is old news. So if transcranial direct current stimulation activates neurons, it will certainly produce a secondary change in vascular function. It's inevitable. If TDCS drives activity in the motor cortex, that motor cortex will then activate a secondary hemodynamic response. And this we know. We have fMRI studies, ASL. There's a lot of imaging studies showing that neuromodulation produces a secondary change in vascular function. That is not what I'm talking about. What I'm talking about is the direct current stimulation or neuromodulation in general, first producing a change in vascular function or blood-brain barrier transport, and then a secondary effect of neurons. This is reversing the direction of traditional neurovascular coupling, right? It's blood vessels first. Why? Well, again, because we have a foreign intervention. And so this is the idea between transcranial direct current stimulation and our interest in seeing whether it can directly activate the vasculature. Now, the problem with addressing this question is no one's going to believe you, because if you stimulate the brain and you see a change in blood supply, everyone's going to say, well, that's because you stimulate the neurons, right? Everyone, even if you look at fMRI, right? fMRI is a hemodynamic imaging response, but everyone just assumes that you're imaging a hemodynamic response to neuronal activation. It's always neurons first. And so how can we establish that TDCS or direct current stimulation affects the blood supply first when the system is so coupled together? It's a very difficult hypothesis to address. One way we can do that is by using animal models where there are no neurons. So these are animal models. Here you have a dish where you have essentially a blood-brain barrier model. But the blood-brain barrier is made of endothelial cells and other cells as well, but the primary shell is made out of endothelial cells. And so you can take these endothelial cells and essentially grow them in a dish to create a blood-brain barrier model. And this is a well-established model. Our addition to it, this shows you the cells, and with these models, you can do many things. You can look at water transport, you can look at solute transport. In the interest of time, I'm not going to get into too much detail, but we can also apply electrical stimulation to these blood-brain barrier models. And what we have shown is very robust changes in activity of these barriers. So one of the strongest effects, or one of the most interesting effects we've seen, is electroosmosis. So we can actually measure water transport across these blood-brain barrier models. And what we found is that direct current stimulation activates water transport in a polarity and intensity specific way. Anode drives water one way, cathode drives water the other way. And it turns out this is based on a very well-established phenomenon called electroosmosis. So it's one of those things, right, where everything sort of new is old. It was sort of expected in a sense, but it was still remarkable to see that when we applied low intensity direct current stimulation, we could push water. We could push water. The water would be dragged with the current. And this is this electroosmosis effect, which I'm only talking here briefly, but I'll please refer you to this paper. And we could do many other experiments in these animal models. One of them is we can look at not just the transport of water, but we can look at this transport of other molecules, small molecules, large molecules. And what we found is that when you drag water, you drag things with the water. And so this suggests also that TDCS can actually enhance drug transport across the brain through this very precise electroosmotic effect. And we found other lasting changes as well that are summarized in this paper. One more interesting result. We reran our computational models, only now we added back the capillaries, right? So you have current flow first flowing through the brain, but as it flows through the brain, it passes through this area with a lot of blood vessels in it. And we predicted how much current will not just flow around the blood vessels, but how much current will cross into the blood vessels. And what we discovered is the blood is more conductive than the brain. And so the current likes essentially funnel into the blood vessels, right? It's like a shortcut. It's like once they can get into the blood, it's like a super highway for them to cross through the brain. The blood-brain barrier itself, however, is incredibly resistive, as I mentioned before. It is resistive to transport, but it is also electrically resistive. The result of having a highly resistive blood-brain barrier and a relatively conductive blood is that you produce extremely high electric fields across the blood-brain barrier. Whereas TDCS produces, we talk about electric field, about a volt per meter in the brain. This is, let's say, the space around the neurons, the parenchyma. Across the blood-brain barrier, we're getting well in excess of 100 volt per meter. So when you do TDCS, you produce a volt per meter around neurons, but over 100 volt per meter across the blood-brain barrier. And this is consistent with the idea that maybe we might be directly activating the blood-brain barrier. I'm going to finish there in the interest of time, and I just want to put it out there that we're not, of course, direct current stimulation still activates neurons. That's what I said earlier on. I'm not taking that off the table. What I want to suggest instead is that there's a parallel mechanism, a vascular activation mechanism. And once you start thinking about that, it leads to very interesting ideas about how we might be using this as a treatment, how we might be using this perhaps to flush the brain in diseases where there's a desire to, let's say, remove plaques and so on. We now have essentially a cap that you can put on that drives water through the brain, clearing the brain out. And we have data from this from animal models, and perhaps even in examples where you might want to use this in a neuroprotective capacity. And I will leave it there. So thank you for your attention.
Yeah. Thank you, Dr. Professor Bixam. I think it was a wonderful talk. There was so much area that was covered in such a short duration, especially the part about, the neurovascular effects of TDCS was very novel to me, and I'm sure it kind of generates a lot of possibilities that you've spoken about. So we have a few questions, so I hope you'll be able to take them up. First was regarding oscillatory TDCS versus TSCS. Can you say?
Yeah, the question was oscillatory DC versus TACS.
Yes.
So there's a form of neuromodulation called slow oscillatory direct current stimulation, or there'll be different words used for it. And then we have obviously transcranial alternating current stimulation. These are distinct. Transcranial alternating current stimulation is applying sinusoidal stimulation such that the polarity switches at a certain frequency, right? So if we're at 10 hertz, 10 times per second, right? Each phase appears 10 times per second, right? So we're flipping current. With oscillating DC, we're not doing it. With oscillating DC, we're applying a current in one direction, then we're turning it off. And then we're once again applying current in the same direction and turning it off. And so from my perspective, they're as distinct. So even though slow oscillatory direct current stimulation has the word direct current stimulation in it, I would consider it a separate technique. It's not a sub form of TDCS. We have TDCS, slow oscillatory DC, and we have TACS. These are separate neuromodulation interventions.
What is the utility of TACS in brain oscillation entrainment? What is your experience with that?
So many studies that use TACS use it in order to engage with brain oscillations. And typically, you would apply stimulation at the frequency of the oscillation you want to engage. So if you want to engage with 10 hertz oscillations, endogenous brain 10, you would apply 10 hertz stimulation. Now from my lab, as well as other labs, there's extensive animal data showing that this is a real substrate. So in an animal model, you can produce oscillations, and you can show very robustly that applying stimulation can engage those oscillations. Stimulation does not produce oscillations. That's an important point, right? You don't produce the oscillations, you modulate ongoing oscillations. It's also been very well established in my lab and also other places that when you match the frequency of the stimulation to that of the oscillation, it's the most potent. So if the oscillations are at 10 hertz and you stimulate at 11 hertz, it is less potent than stimulated. So there's this notion of frequency matching. And what's very interesting is that there's emerging literature in the clinical domain. The Robert Reinhardt lab just published a paper, I think a few days ago in Nature Medicine. And they published other work like this as well with a frequency match So again, they record this is the imaging part. You record the person's endogenous oscillations, and then you personalize stimulation to match their endogenous frequency. And again, so this idea is very cohesive with what we know from the animal data. And it's consistent with the idea that TACS is often rationalized to engage brain oscillations. Of course, it is more complicated, right? The brain is so complicated, but that is the beginning of the story.
So why are the electrodes so large?
I think the size of the electrodes is appropriate for the given indication. So, for example, obviously, a lot of the traditional work that Dr. Nietzsche did, he started with 5x5, 5x7 centimeter electrodes. He was also able to move those electrodes around the head and, importantly, show position-specific effects. That was very important, right? So it matters where you put these large electrodes. A majority of ongoing TDCS work continues to use relatively large electrodes, building on his work and other important trials. Obviously, there's also the ability to use smaller high-definition electrodes and deploy them in arrays. When might you do this? If you're very, very concerned about stimulating focally, it gives you more flexibility. The paper I just mentioned from Reinhardt's lab used high-definition stimulation in order to drive current to a particular region of interest. So more channels, like with anything, is going to give you more flexibility. However, I also talked about home use. You can't use, right now, there's work on this, but high definition is not really robust at home. So in that case, we will rely on relatively large electrodes that are easy to self-apply at home. So I think the selection of electrode size really comes down to the question you want to answer, but also the literature base that you want to build on. You know, if there's great results using a certain montage, there's a very strong incentive to continue to replicate it. So I wouldn't say I would, everything's relative, right?
So I'll just take another couple of questions because we have the other speakers also. So I just wanted to ask you regarding your experience with regards to the home-based treatments that you talked about. How comfortable and how well accepted is that kind of intervention with regards to patients of varying, ease with technology? I mean, in our country, for instance, I would imagine that many people might not be comfortable or there might be some kind of resistance to using such technology at home.
So your point is very good. The home use must be population specific. These patients have MS, right, or Parkinson's. It must be region specific. What is and it should also be time specific. Like, do you have a pandemic? You know what I mean, and so on. So that's why we talk about a rubric rather than rules, right? And so I can tell you that most of the experience I know has been in the United States, and the experience has been very good. Very high compliance. In fact, ironically, higher compliance than in clinic, because it's very hard to get people to come in 5 days a week in the winter for 8 weeks when they're already severely disabled. But the home use compliance is extremely high. That is an outcome measure of these trials. There's also compliance in the sense that were they able to apply correctly and so on. And again, the experience so far has been very successful. But again, I want to qualify that it has only been successful because the researchers and the clinicians have been so systematic in how they have deployed it. But including patients with severe disability, severe MS, Parkinson's, it has been successful. There are situations where people may be so disabled that they cannot self-apply it. So then what we use as a proxy. So there's remote supervised TDCS trials, for example, for palliative care. And in that case, you would have a nurse, perhaps even a family member, who is playing the proxy role. Again, it's all part of this remote supervised rubric where you never just send out the device. You exactly what you said. You have to think about who are you sending it out to? What is they're familiar with the technology? Do they have an internet connection? If you're requiring an internet connection? So this remote supervised can also, by the way, work by phone. So the technology that I at least work with doesn't require an internet connection. You can substitute that with a phone call. but it is what you're saying is such an important point. Do not just send out devices.
So have there been any efforts to understand the clinical benefits of improving blood-brain barrier permeability using TDCs, especially for better drug delivery, for instance? I can imagine it might be a little, dangerous in certain situations as well.
So the short answer is well, yes and no, because one area, for example, I would be very interested in brain clearance. Blood transport boosting mechanisms would be age-related cognitive decline, MCI, Alzheimer's. Obviously, there's an interest there to boost brain clearance. Now, the trials of TDCS for these indications, you could talk about Parkinson's, other things as well, they're already ongoing. So in a sense, the clinical work is already ongoing, but based on a different mechanism, right? The mechanism there is neuronal. So that's why I talk about a new mechanism for an old treatment, right? The treatments are already ongoing, and now we're sort of playing catch up and saying, could this be an additional mechanism? There are ways to, this is a testable hypothesis, however, right? There are imaging techniques to image transport in the brain, and those right now, that work is ongoing. We've just started that work. So I should say that the idea that I've put out here is an early one, but people, for example, have used ASL to directly image blood flow in response to TDCS. So the data is there. It's just that people never interpreted that as TDCS activates blood flow. They interpret that as TDCS affects neurons. So in a sense, the data is already there. This is just a different lens on it. And we need to design new experiments in people to dissect out which came first. Those are hard experiments. As far as safety, just really quickly, as we know before, TDCS is safe. So we're not, again, it's not a new technique. If it was a new technique, you might say, well, what are the safety concerns? We have decades of safety data, decades of safety data from transcranial direct current stimulation. So based on that, I believe, again, it's a new mechanism for an old technique for which we have the safety data.
All right. So I think there's a couple of other questions that we'll take up at the end because they're a little more general. So now I'll invite Anirban to make his presentation. I'll just introduce him. Anirban is a good friend. We keep talking about various stuff. And he received his PhD from Case Western Reserve University in Biomedical Engineering. His doctoral research work is in neural engineering and postdoctoral work at the Geniella Farm Research Campus, a Rehabilitation Institute of Chicago, and University Medical Center in Göttingen, Germany. Provided him with training in neurosciences following his postdoctoral training in clinical neurophysiology and a second MS in cerebrovascular medicine at Germany. He currently conducts translational research work in neurosciences and neurology. He's currently in Buffalo University at Buffalo, and he's going to present his talk on neuroimaging guided cerebellar TDCs. So, Dr. Datta, please take it from here.
Thanks, Dr. Singh. Thanks for the nice introduction. Can you see the slide?
Yes.
Okay, slide. Okay. So yeah, first of all, I would like to thank Professor Nidze and Professor Bixen. In fact, this work that I would going to present is started in his lab when I was a postdoc there. And in fact, this work that I'm going to present uses the computational pipelines that Professor Bixen's lab has given for free. Actually, it's the open source data, open source pipelines that we use in our lab to do cerebellar TDCs. So I'm going to take this cerebellum as the target of brain stimulation, and the idea is why cerebellum. So cerebellum has been considered primarily a part of the motor network. However, recently there's a lot of work, especially from Schwamann's lab, that have shown that cerebellum has even non-motor effects, and also it's related to virtually all aspects of behavior. Now, when I talk of cerebellum, so one of the challenges with cerebellum is its structure. So it's a 3D structure, and it's very difficult to stimulate and also to visualize in terms of how the activations, lobular activations are related to tasks. So that's why in this talk, I would be using a flat map to show the cerebellum, which is from the Didrikson lab, and they call it SUIT atlas, and it's a spatially unbiased atlas for cerebellum. So on your left, you see that a 2D map of a 3D structure, and you can see different parts of the cerebellum, which are the lobules, as is shown with different colors. So cruise 1, cruise 2. I would be talking a lot about those two because of the cognitive aspect. But also there are other lobules which are motor, and also so that's what is shown on the right. So if you look at the summary, then I show these 3 colors. So the blue is for the motor processing, then the yellow is for the attentional executive processing, and then the red is the default mode processing. So if you then look at the cerebellum, you see that there's this transition, right? So on the top, you have this blue, which is lobule 1 to 6, and then from 6 to cruise 1, you have the transition towards the default mode. And then as you go on the other side from cruise 2 to lobule 8, you again go to the motor. And then from there to lobule 9 and 10, it's primarily default mode processing. So now this is, interestingly, this can be reduced into this 2 functional gradients, and this is something that we are interested in how we approach stimulation. So if you look at this distribution, so by distribution I mean if you take any location in the cerebellum that can be mapped into this 2 on this 2 functional gradients, that's the D on the top right, and then you see a blue part of that, that's basically the motor processing. Then you have this yellow part of it, which is the attentional executive processing, and then you have the default mode. So any location in the cerebellum can be mapped to that, on this 2 functional gradients, and that will determine how much of it is related to, or how much of it is a part of motor processing versus attentional executive processing versus default mode processing. Now I won't go too much into, so I would like to say that this evidence comes from multiple studies, which are primarily fMRI studies, and they are based on task activation, which is, for example, left hand motor task, working memory task, then also seed-based resting state connectivity. And then when you put everything together, all the studies together, then this functional gradients kind of emerge out of the signal processing or the analysis of the data. And if you look at the bottom right, you see that there are different colors that I have shown on this SUIT flat map. Again, these are different parts of the cerebellum that are related to different tasks. For example, the blue is motor task, the green is the working memory task, etc. Now that's the task processing part of the data, but if you even look at the resting state network, so this is quite well established that we have, this is quite well established for the cortex, that we have certain resting state network like default mode network, frontoparietal networks. But it's interesting that they also are, so there is a cerebellar aspect to those networks that we don't discuss that much. And one of the 2 of the networks that I would be discussing in my talk today are this frontoparietal network, which is shown in orange, and then the default mode network, which is shown in red. So, so that's kind of like the overview of how we see cerebellum as our target for TDCS, for transcranial stimulation. Now, the application that we're talking about is aging, and it's in dementia. So we first have to understand how cerebellum is related to this, to aging, and especially to this network-based degeneration. So now it's being established that the cortical atrophy that happens with aging, for here we talk about Alzheimer's disease and the frontotemporal dementia. So during this, as the cortical atrophy happens, there is also an atrophy in the cerebellum, and they are related. And they are related in a network-based fashion. So for example, if you see on the right, I'm showing this 4 plots. If you look at the top left, that's the cortical atrophy in Alzheimer's disease, which is known to be related to the default mode network. And on the x-axis is the left cruise 1, shown the atrophy in the left cruise 1. And on the y-axis is the atrophy shown in the left angular gyrus. And if you see that on the top left, there is a kind of a linear relationship. So they are related. And since left cruise 1 is a part of the default mode network. However, if you now look into the relation between the right anterior insula, there's not a relation because that's a salience network. So cruise 1 is not a part of that network. Now, if you look on the right, now it's for behavioral variant of the frontotemporal dementia. It's the opposite because that's where the salience network is affected, and you see a relation between lobule 6, left lobule 6, and the right anterior insula. So you see a relation, and of course, right anterior insula is a part of the salience network, and you have a relation of that to the atrophy at the lobule 6. However, if you look at the default mode network, again, that's top right, you don't see any relation. That's with the left angular gyrus. So this kind of shows that cerebellum is a part of these networks, and as that network degenerates with aging and eventually in dementia, there is a effect on cerebellum as well. So now, what's the challenge currently, or what's not just challenge, but what's missing? So right now, so there is indeed a lot of studies going on in dementia, and of course, the main target that we can think of is the dorsolateral prefrontal cortex because it's a part of the frontoparietal central executive network, and in fact, as you can see on the top right pictures, I show this default mode network, limbic network, frontoparietal network, and the salience network. So in the early onset Alzheimer's disease, which is before 65 years of age, you actually do have this effect on the frontoparietal network. Effect means in terms of cortical atrophy, there's an effect on the frontoparietal network, and that's is on the executive functions. And then in the late onset Alzheimer's disease, then the default mode network and the limbic network gets involved, and you then have memory. The person then have the memory issues. And in the frontotemporal dementia case, it's a salience network, as I've discussed earlier. So in this talk, I would mainly be focusing on the Alzheimer's disease because that's what we are doing in India. So I would present some results there. However, just to kind of understand this better, so on the left, I show this picture from one of these a large study in US that places the anode and cathode on the DLPFC, as you can see, F3, F4, and then they primarily target the DLPFC, and that's basically, like I said, is a node of the central executive network. What we are saying is that we need to also we need to stimulate the network, and then cerebellum may play a major role there. And I will soon tell you why cerebellum can play a major role as a node in this network for TDCs, for brain stimulation. So now we look at this paper that came out in 2018, the cerebellar connection in frontoparietal network. Okay, so what I'm showing in terms of the picture here is on the left is how much of the cerebellar volume is represented by different networks. So red, for example, is default mode network, then the yellow is the frontoparietal network, then green is the dorsal attention network, etc. Same with cortex, you can do the same, but that's for the cortical surface area. You can also do the same thing. So you can say, okay, how much of that, by how much, I mean, what percentage of that total is represented by default versus frontoparietal versus dorsal, etc. Now, what's interesting is that there is basically a linear relationship. So that's shown by the plot C, where the percentage of the total cortical surface area for different networks, they are markers in different colors. They are related to the percentage of the total volume of the cerebellum, so cerebellar volume. And they are, like, in terms of percentage, they are related. What's interesting is that the frontoparietal network is basically overrepresented in the cerebellum. And the frontoparietal network is shown in yellow marker here. And if you go to the D plot, you see that very clearly that, like yellow bar is quite high compared to other bars which represent other networks. So it's almost 2.5 times overrepresented in the cerebellum than in the cortex. Now that's one part of the story. The other is how it's related. So this paper does a nice job in also showing this time delay. So what it's showing on the right, so it's showing a lot of things, but let's just look at the this dark black box, sorry, black box. And then within that box, what it's showing is the, so these are bold signals, so it's a time series. So what's the lead or lag between the cerebellum and the cortex? So what is showing is a lot of red. What that means is that cerebellum lags the cortex when you look at the bold time series. So basically this paper then postulates that this infraslow activity, 0.01 to 0.1 hertz, is related to this delta band activity in the cerebellum. And it's a phase amplitude coupling between the cortex and the cerebellum. And this is an interesting postulate that I will come back to this by the end of this talk. So this is kind of a selling point of why cerebellum is important in the frontoparietal network and in dementia. Like I've shown earlier, that's in early onset Alzheimer's disease gets affected. So an intervention at an early stage may be necessary at the cerebellar level. Okay, so now one of the challenges with cerebellum, if you go about stimulating cerebellum, is the shape of the cerebellum. So it's a 3D structure, and because of that, we have to have a rational approach to stimulate it. And by stimulation, we need to make sure that we are providing the same dose or same amount of, so like Professor Bixson mentioned, is the electric current that flows through that volume, or it can be electric field, but it needs to be consistent across subjects. So that's only when we can say that, okay, we did stimulate it, and there's not much variability in how we stimulate the structure, and that's why the behavioral variability we can relate to based on that. So now what we did is we developed this pipeline. So this was done by Janab Rezai in my lab. So we used this age-appropriate human brain MRI templates. They were in 18 age groups, and we got that. Then we created a head model. This was done, I think, in ROAST. And then we extracted the electric field distribution from ROAST. Then that electric distribution was mapped to the suit flat map using, so it was done outside of ROAST using our code. And what we investigated is, if we use the Selnick montage, which is this one-size-fits-all montage for cerebellum stimulation, where this 5 centimeter by 5 centimeter is placed over the right cerebellum, 1 centimeter below and 3 centimeter lateral to inion. And then we have another 5 centimeter by 5 centimeter cathode on the buccinator. And if we inject 2 milliampere, how the suit flat map looks that represents the electric field distribution in the cerebellum. And I will go into this in more detail, but just kind of, if you look at this on the right, the pictures, these are like for different age groups that we got from this age-appropriate human brain templates. You see that there is a lot of difference. So with one-size-fits-all montage, you do stimulate different lobules depending on what age group the subject belongs to. And this is more clear if you look at what's causing this. So with aging, it's known, and also we saw in this template that there's change in the cerebrospinal fluid volume with aging. And there's also change in the cerebellar volume with aging. So the CSF volume increases and the cerebellar volume decreases with aging. And then with that change, if you then map to what's happening to the maximum electric field in the left cerebellum and the right cerebellum. So these are on the right, the top two plots. You see that with an increase in the CSF volume, there's a decrease in the maximum electric field in the left cerebellum as well as on the right cerebellum. However, if you look at what's happening with the cerebellar volume, so as it increases, the maximum electric field in the cerebellum also increases. So this is kind of causing this distribution of electric field to change across age, and this is one of the aspects that needs to be investigated, because as Professor Nidze kind of showed that, so the current has different effects. So he showed in terms of a neurophysiological effect, but it may be related to the structural change in the brain with aging. So the same current, if you use, will lead to different electric field strength in the cortical tissue, and that probably means that one needs to use a higher current to stimulate in the older subjects. Okay, so now what's the solution here? So now the solution that we provide here is, like I discussed earlier, is this modeling, which is based on ROAST, and which is an open source pipeline from Professor Bixen's lab. So here you can take, of course, individual's own MRI if it's available. Otherwise, you can take an age specific from these templates that are available, freely available. And then you use that to create the head model. Then you run in ROAST the simulation to find the electric field distribution in the brain. And then you take that electrical distribution and then put it in suit to map it to different lobules of the cerebellum. And then, of course, you can run optimization using that. So by optimization, what I mean is we try to find out if we have to target a certain lobule or certain group of lobules where we should place the electrodes. So that's basically this pipeline, which is called closed cerebellar lobule optimal pipeline or stimulation pipeline. Now, as you may imagine, or you may already know, that we don't know the tissue properties, right? So we'll always have this uncertainty. Even if we get the best structural MRI model, structural MRI based model, we still won't know what would be the conductivity of different tissues and what's the difference between subjects. So we'll never be perfect in this kind of this modeling approach. So we need to have a way to measure during stimulation what's happening. So what's the response to stimulation? So now, of course, Professor Bixen mentioned this EEG and FNIRS. Now, EEG is an electrical technique to find the activity, neural activity, and so since we are stimulating with electricity, then there's an artifact that you see in the EEG. However, functional near-infrared spectroscopy is optical imaging technique which doesn't get affected by this electrical stimulation. Now, as Professor Bixen mentioned, and also Professor Nidze kind of indicated, that the electrical stimulation can have this effect on hemodynamics. So this optical technique measures hemodynamics, but then that effect on the hemodynamics can be via neuron or can be directly on the vessels. So there has to be a way to delineate the two in the model. And we have done some work, and we have a paper in the response time would be different if it's through neuron versus if it's directly on the vessel, and that may be a way to dissociate between these two effects. However, if we don't kind of go in that depth, basically what we can see is that when you stimulate with TDCs, you see an evoked response with FNIRS, and this is related to the response that has been shown with fMRI and with ASL kind of approaches. So what we did here is we used a low-cost device, because the study was done in India in stroke, and we used this 8-channel EEG and 8 sources to detector FNIRS to kind of get a proof of concept what's happening when we are stimulating the cerebellum, what's happening in terms of the EEG and FNIRS responses when you're stimulating the cerebellum. So this is, so I won't go too much into detail in this for the study, but what I would like to kind of show is that we had this 2 montages. So one was to stimulate the kind of like on the right, it's called dentate nuclei cerebral TDCs, which kind of has a uniform coverage of all the lobules. And on the left, we are only stimulating the leg area of the cerebellum, which is lobule 7B to 9. So these are two different montages that we used in stroke. This was a standing balance study, so that's why we have this leg representation as a target. And we did it on 12 subjects in India, chronic stroke subjects, ischemic stroke subjects in India, and they, as you can see, is so they have like more than a year. So we did it after a year of stroke. Now, so there's a lot of results that we have published in terms of their effects on the balance, standing balance. However, what I would like to highlight is this kind of a reasonable linear fit between the electric field strength. So this is the electric field strength in the cerebral lobules and the oxyhemoglobin change in the at different parts. So like I showed, we didn't have a high density FNIRS. It was kind of targeted towards prefrontal cortex and the sensory motor areas of the cortex. But we did see a somewhat a linear fit, and the goodness of the fit is shown on the right. So on the left is this. So the paper kind of details this better, but here just I wanted to highlight that there seems to be a linear relationship between this electric field strength and the evoked response in the oxyhemoglobin, as well as in the EEG band power. And this is not during stimulation, but it was done post versus pre intervention. And then the residuals also have the standard residuals also have a nice bivariate normal distribution. These two subjects who didn't fit are the ones who actually had a basal ganglia infarction. So these are all MCA, middle cerebral artery patients, stroke survivors. And this two subjects had a basal ganglia infarction, so they didn't fit this GLM model well. So this was a preliminary proof of concept data that showed that FNIRS may be a good way, way to measure the response for dosing electric field strength, because we would never be perfect with our modeling. And so we have to have a measure, online measure. So now, so I would like to highlight now, so based on this proof of concept, we now are trying to integrate this in a dementia study in India. So this is in collaboration with Professor Uttama Lahiri at IIT Gandhinagar and Dr. Abhijit Das at the Walton Center, NHS Foundation Trust in UK. So, so this study was, so there was this ongoing study in India where we are interested in seeing if eye tracking can be used as a measure to screen mild cognitive impairment. So this study was done in with 400 participants. So in Hooghly district in West Bengal, there were 350 participants. Then in a tertiary care hospital in Kolkata, there were 20 participants. And in an old age home in Gandhinagar, there were 30 participants. And if you look at this study, then we had subjects from age above 45 years. So we were also looking at this early onset of Alzheimer's disease. So I would just like to, so this is a manuscript under submission. However, I just want to highlight that what we found is that there is this gauge-related markers of anti-saccades and pro-saccades that actually are correlated with this ACE3, which is this Addenbrooke's Cognitive Examination 3, which is used for diagnosis as an adjunct to the full clinical assessment. So there is this relation, and this gives us some confidence that eye tracker-based metrics may be used as for screening dementia at a point of care setting. Now, what we are postulating now, this is for the brain stimulation, that the cerebral transcranial stimulation in these patients, if we target the screws 1 and 2, which are cognitive part of the cerebellum, may improve this gauge-related markers of attention and response inhibition. So this is an ongoing study. And then I would like to finish with this proof of concept study that we did in young and healthy. So here what we are trying to do is, so we are using just 4-channel FNIRs because of the cost aspect, because we want this to go in the field, in in a community setting. So this device has only 4 channels. However, this covers the prefrontal cortex, and we are using the infra-slow oscillations in the oxyhemoglobin to do a phase amplitude coupling with the 4 Hertz TACS, transcranial alternate stimulation. So although this talk is on TDCs, but I would like to mention that transcranial alternate stimulation can be also be effective in cerebral stimulation. And this phase amplitude coupling is based on this paper that I discussed at the earlier part of my talk, where this has been found for the frontoparietal network. And we are trying to see if we enforce that with stimulation. Can we enhance that network performance? And indeed, so this study was done in young and healthy subjects, in 10 young and healthy subjects. And we compared our TDCS approach that we already applied in stroke, and we did find encouraging results with FNIRS, with the cerebral TACS approach, transcranial alternate stimulation approach, with this phase amplitude coupling. And interestingly, using the same measure, so the metric that we are using is this post change in the oxyhemoglobin concentration from pre-intervention baseline divided by post plus pre. So this is normalized measure. We found that the cerebral TDCs led to a mean increase about 0.36. This is across, not mean, a median increase across bilateral PFC by 0.36, where cerebral TACS, transcranial alternate stimulation at 4 Hertz, led to an increase of 0.67, which was almost double. So we are very encouraged with this results in young and healthy, and we'd like to see if we can get similar effects in elderly. So that's the end of my talk, and I would like to acknowledge the graduate students who worked on this project, not just from my lab, but then all collaborating labs. So Dr. Janab Rizai, Dr. Dhaval Solanki, and then Mr. Shashi Ranjan, Ms. Fei Zhao, then Mr. Pushpinder Walia, and Ms. Kavya Kumar. Thank you very much.
Thanks a lot, Anirban. We mute him? Yeah. Thanks a lot, Anirban. I think this was an interesting talk. We usually talk about targets being, F3, DLPFC, or motor cortex. Anirban has spoken about using cerebellum because cerebellum has a fairly large, surface representation. And also, he's just demonstrated how, the brain is connected in the sense that you have a very remote manifestation of a stimulation at the cerebellum, and you can actually pick it up at the frontal cortex, for example. And to also use something like FNIRS as as a medium of demonstrating change. So I think all of these are very important. I'd like to ask Anirban as to what is the advantage of using, say, cerebellum as a target over more conventional sort of targets like F3?
Yeah, so we are actually interested in seeing if this network-based approach, so where we do have a, so we can stimulate the DLPFC, but also we coordinate the stimulation of cerebellum with the DLPFC, as was shown by this paper that there is this phase amplitude coupling. So if we can enforce that with stimulation, we may actually enhance the effect. So here the hypothesis is that stimulating a single node versus stimulating 2 nodes may have a better effect. And when we say 2 nodes, of course, DLPFC is established, so we would have that. But then other than DLPFC, we then looked at which node may have the large representation of this frontoparietal network. And indeed, cerebellum has a much larger representation than the whole cortex in terms of the percentage of its volume. So that's why we think that if we do this 2-node approach of DLPFC and cerebellum, and in a coordination where we have this 330 to 350 millisecond delay in terms of phase amplitude coupling, we may be able to enhance the effects of the stimulation.
So yeah, I think it's very interesting that there are lots of possibilities out here, and it can possibly lead to better targeting and better reproducibility of mechanisms rather than the conventional methods that we've been using so far. So we'll take up some more questions in the panel discussion, and I think now we can listen to Dr. Janardhanan if he's around. Dr. Janardhanan?
Yes.
Yeah, so I'll just introduce him. Dr. Janardhanan, again, is a good friend. He's an associate professor of psychiatry at NIMHANS, Bangalore. NIMHANS is one of the premier institutes of neurosciences in the south of India. He's also a consultant at the Weiser Neuromodulation Program and OCD Clinic. He's a Wellcome Trust DBT India Alliance Intermediate Fellow, and his areas of interest are neuromodulation and OCD. He has special interest in exploring the role of non-invasive neuromodulation in the management of treatment-resistant OCD and also schizophrenia. His current research activities include neurobiological and clinical effects of TDCs in OCD. And when he's not doing all of that, he runs a YouTube channel, which I just spoke about. He sings a lot, and he has a YouTube channel called Copy Break, and in fact, two of the main culprits of that channel are here right now on at the Zoom platform. So I would request all of you to have a look at his channel whenever you have the time. But right now, he's going to be talking about more mundane matters like TDCs and schizophrenia. So thank you. Please go ahead. Mute कर दो.
Am I audible now? Can you hear me now?
Yeah, but not that clear.
Okay. How's it now? Am I audible now? Yeah. Thank you very much, Dr. Shubmohan, for the introduction, and thank you very much for inviting me and giving me this opportunity to discuss this topic. I will be discussing the role of TDCs in schizophrenia therapeutics. And this has been an important area which our group has been working for the past 8 years or so. And our group is led by Dr. Venkat, who is my senior colleague. And the reason why this particular, the reason why we thought of looking at TDCs in schizophrenia is because of the sheer numbers of patients that we end up treating with schizophrenia. It's a major psychiatric disorder which has an early onset, mostly in early adulthood, runs a chronic course in many cases, and the occupational and social dysfunction that comes with this disorder is pretty huge. And overall, patients lead a life with poor quality of life in general. When you look at the phenotype of schizophrenia, it's pretty complex to interpret and treat, primarily because most of the conventional medications, the conventional treatment options that we have in schizophrenia treatment, antipsychotics in particular, are specifically meant to be effective for positive psychotic symptoms, which are delusions and hallucinations. And then you also have another set of symptoms which are pretty hardy to treat, negative symptoms and the cognitive deficits that come with schizophrenia. The disease burden is pretty huge, and what also comes with the treatment is a resistance to conventional treatment options. And patients generally have a lot of difficulty in adhering to medications, mostly because of the insight factor, which is lost in schizophrenia. And antipsychotics also have a lot of metabolic and neurological side effects. And the resistance results in a lot of burnout issues and cost-related factors. So it's a clinician's dilemma at a certain point when you have patients with treatment resistance. When you look at the roadmap to understanding and treating resistant schizophrenia. The future research or roadmap talks about how identifying biomarkers and mechanisms underlying treatment resistance is important. And at the same time, novel treatment targets and precision medicine is considered to be the next method which has been postulated now. And in that context, one needs to explore novel treatment approaches and targets for schizophrenia. And what is relevant to the understanding of schizophrenia is pathogenesis, is the neuroplasticity pathways that play a key role in the pathogenesis of schizophrenia. When you look at the various neurotransmitters that are involved, be it glutamatergic, dopaminergic, and GABAergic medications, there is a good deal of neuroplasticity mechanisms in play. And the hypothesis also includes neurotrophins in the pathophysiology of schizophrenia. And some of the neurotrophic factors, peptide molecules, seem to be quite important when it comes to plasticity modulation. For instance, some of the earlier work from our lab includes looking at the relationship between the symptoms and insulin-like growth factor. Am I audible? I get a feedback that the audio is poor. Am I audible now?
Janardhanan,
Yeah.
it might help if you spoke closer to your microphone.
Okay. So let me know if I'm audible now. I'll continue.
Yes, you are audible. You were breaking a bit. I mean, the sound quality is not great even now, but at least it's not breaking anymore.
Okay. Yeah, so I was talking about the relationship between neurotrophic factors and schizophrenia in neuroplasticity modulation. When you look at the positive symptom score as particularly hallucination score, it seems to be having an inverse relationship with insulin-like growth factor 1 levels, for instance. And the subsequent study with another important neurotrophic factor, brain-derived neurotrophic factor, BDNF, there is a relationship between BDNF and Schneiderian first-rank symptoms. And this has been shown by a German group wherein they have examined BDNF and plasticity in some of the basic experiments using motor evoked potentials. What has been seen is that there is a significant improvement in motor evoked potentials after TBS in a specific phenotype, homozygous phenotype of BDNF, meaning to say that BDNF might play a significant role in plasticity mechanisms. And some of the critical brain regions that are involved in this, as far as schizophrenia goes, is hippocampus. The region of interest study from our center with BBM analysis looks at hippocampal gray matter volume, showing BDNF genotype by diagnosis interaction, wherein VAL homozygous patients of BDNF showing a significantly smaller hippocampal volume compared to the other groups. So the overall mechanism which we would like to propose is that there are genetic and environmental interactions in place, and neuroimmune factors as well as neurotrophic factors have an important role to play in plasticity mechanisms. And this might specifically affect the hippocampal network abnormalities and finally result in the symptoms of schizophrenia. So this is a postulate which is interesting to look at when it comes to harnessing the neural plasticity mechanisms in schizophrenia. So TDCs might have an important implication in this. And there is a clinical research program which is running in IMHANS called the Weak Intensity Stimulation for Enhancement and Reintegration. We've made an acronym called WISER. And the standard operating procedures for TDCs, HT-TDCs, and TACs is being followed. And we've been able to successfully implement add-on TDCs for treating some of the psychiatric disorders like schizophrenia, OCD, craving, depression, etc. And some of the novel applications like targeted intermittent booster TDCS sessions have been examined. And over the past few years of administering TDCS, we have been able to infer that there are no significant adverse events, leading to dropout of patients despite administering TDCS over 3,000 sessions. So that in that context, TDCS seems to be safe, and it seems to be a potential alternative, at least as an add-on treatment in psychosis. As mentioned by Michael during his talk, TDCS has an effect on neurotransmitters, and anodal TDCS probably inhibits GABAergic transmission, while cathodal TDCS might have a role on glutamatergic transmission. And the TDCS direct current stimulation results in long-lasting synaptic potentiation, and this has been explained quite well by Michael. And this may be dependent on BDNF secretion, with certain genotypes of BDNF showing a greater synaptic potentiation than the other. So I'll introduce certain clinical studies that were done. I'll summarize some of the clinical studies that has been done here. This has been based on one of the initial study, which was published in 2012 by a group from France, examining the role of TDCS in the treatment of hallucinations in schizophrenia. So auditory verbal hallucinations were the primary outcome measure in this particular randomized control study, which was designed in a double-blind design. And what was found is that true TDCS or active TDCS resulted in a significant reduction of auditory verbal hallucinations compared to sham stimulation. And the effect was noticed at the end of 1 week, and it was followed up for a month and at the end of 3 months as well. And effect persisted until 3 months of the observation period. And what was also noticed in the study was a significant improvement in negative as well as positive dimensions of PANSS rating in schizophrenia. Now, what might be the basis or the target for this improvement is based upon the understanding that positive psychotic symptoms such as delusions and hallucinations in particular, they can be pinned down to temporoparietal junction hyperactivity in schizophrenia, and this also correlates with an increase in glutamate level, while the negative symptoms such as amotivation, avolition, and alogia are associated with a deficient activation of prefrontal cortex with a reduced N-acetylaspartate level. So this is considered to be one of the mechanisms or the postulates based on which this montage of TDCS stimulation in schizophrenia has been designed. So the protocol is placement of anode over left dorsolateral prefrontal cortex, midway between F3 and FP1, and cathode is placed over left temporoparietal junction, which is midway between T3 and P3. And the electrode size is 35 centimeters square, and the stimulation intensity is 2 milliamperes, and duration is for 20 minutes. And the course of treatment for the trial was for 2 sessions daily for 5 days and intersession interval of 3 hours. So this has been the protocol which was followed by the Brunelin group, which published the first RCT in 2012. And when we used it as an open label observation in the initial phase, we found some encouraging results with 20 odd participants, and we found that there was an improvement in auditory hallucinations. And at the same time, there was an improvement in insight rating for these patients as well. And some of the patients becoming more amenable to treatment and more amenable to taking medications also at the end of it. We followed this up with a very similar design to what Brunelin and colleagues did, using a randomized sham-controlled double-blind design. Frontotemporal transcranial current stimulation was used in patients who were non-responders to at least one antipsychotic medication. They were randomized to receive either true TDCS or sham TDCS, and the protocol was for 5 days, as I mentioned previously. And at the end of 5 days, if the improvement is more than 30%, the study was considered to be complete. If the improvement is less than 30%, they were offered an open label extension of true TDCS for another 5 days and then reassessed. This is a finding of the study. What was found is that true TDCS had a significant benefit compared to sham TDCS on auditory verbal hallucination rating. And this is at the end of 1 week of 5 days of randomized controlled phase. And there were some people who received sham TDCS and they were crossed over to the true TDCS on the next week for an open label extension. Interestingly, this crossover also showed that when you cross over to an active TDCS arm, you find improvement happening in the second week, meaning to say that there is definitely an effect of the stimulation type as far as the stimulation goes. The French group also published the changes in functional connectivity with improvement in auditory verbal hallucinations in their subjects. What was seen is that the active TDCS at the end of stimulation reduced the resting state functional connectivity of left temporoparietal junction with anterior insula, inferior frontal gyrus, while in certain other regions such as DLPFC and precuneus, there was a reduction, there was an increase in resting state functional connectivity. Of interest, the reduction in auditory verbal hallucination severity was correlated with reductions in the resting state functional connectivity between the seed region of temporoparietal junction on the left side and the left anterior insula. So the findings concluded that perhaps the reduction of verbal hallucinations induced by TDCS is also associated with the modulation of functional connectivity within the AVH-related brain network, which are regions involved in inner speech monitoring and production. We followed up a very similar design to look at what happens to our subjects. Very similar findings, and true TDCS led to reduction in the resting state functional connectivity of TPJ with left frontal regions, which are the regions involved in speech production, source monitoring, and a particular paradigm called corollary discharge. We'll come to that. I'll come to talk about it later. So as it was mentioned previously, the conventional TDCS differs from high definition TDCS in a number of ways. It uses a larger electrode. It might result in diffuse and variable stimulation. And it always has to stimulate and inhibit, which means that here we need to find an area to stimulate and an area to inhibit. It may be less amenable for advanced modeling to implement precise stimulation, and the outcome could be unpredictable and variable as far as the clinical outcome is concerned. So in this context, high definition TDCS might offer some advantages. As you can see, the size of electrodes is quite small, and you can stimulate one particular brain region with a particular polarity of electrode, and the surrounding electrodes can be of opposite polarity, and it might be more amenable for advanced modeling. So this might be a promising way ahead. So what differentiates these two, as it was discussed in one of the previous talks as well, is that conventional TDCS might result in diffuse stimulation, whereas FT-TDCS might result in a focal stimulation with a peaking of voltage under the electrode. And perhaps the neuroplastic effects were longer lasting than the conventional TDCS. So using this, with this idea in mind, now the protocol that we follow for high definition TDCS involves using central cathode over left temporoparietal junction and the ring surrounding electrodes, assuming the anodal configuration around that particular electrode. So we just use one particular region when we use HT-TDCs. Some of the initial observations in an open label fashion tells us that HT-TDCS also seems to be helping patients, and when we find improvement happening in auditory hallucination rating as well as in overall positive symptom rating when we use high definition TDCS. How does the improvement happen is an important question, because when we talk about the improvement in auditory hallucinations and auditory plasticity, there's an important paradigm which can help us understand why would this improvement happen. And one such important paradigm that we have been examining is corollary discharge. Now, this mechanism helps a person distinguish a self-generated action or a self-generated event from a non-self-generated event. For instance, when we try to vocalize something, when we make an attempt to vocalize something, the motor cortex gives an efferent copy or some kind of a feedback to the auditory cortex that, look, I'm going to say something, and whatever I'm saying something is not to be given so much of importance. You don't have to look at it like somebody else is talking, like a regular voice. So that's a talk condition. Whereas when you listen to something, auditory cortex listens to it in a complete way. I mean, I'm just making it in a much more simplistic manner. So when this efference copy is produced, it's called a corollary discharge. And what happens is the auditory cortex suppresses this event, which is understood as an N100 event in EEG. And the talk or the speech sound is suppressed relative to the N100 that is produced from the same sound, which happens through listening. So you make a person vocalize something like ah or something, some vocalization, and you record it and play it back to the person. It becomes a listen condition. And when the person talks the same thing and listens to it while he is talking, it becomes a talk condition. So what happens in health is that during the talk condition, this N100 is suppressed, while in listening, N100 amplitude is longer or larger. While in schizophrenia, and there is a relative failure of this efference copy, and the corollary discharge appears to be deficient. And this particular paradigm is interesting to examine using TDCs. So what was examined here is that this particular figure gives you an idea regarding in schizophrenia, this difference between the talk and the listen paradigms as far as N100 goes is not very different. It's not wide, while in health, it seems to be quite well separated. So we examined this question, our colleagues in the lab examined this particular question using TDCs and trying to look at what happens to this after TDCs. What was seen is that this defect, which is seen at the baseline, seems to be reversed after giving TDCs to patients. So meaning to say that there is a possibility that this mechanism could be an explanation as to why auditory hallucinations improve with TDCs. And this was also examined in a randomized double-blind sham-controlled analysis, looking at what happens to corollary discharge. So true TDCS seems to be showing a beneficial effect comparing with sham TDCS. Now, the other important question is whether TDCS is useful for the other symptom dimensions of schizophrenia, such as negative symptoms, cognitive symptoms. Negative symptoms, as we know, are pretty difficult to treat. Conventional treatment options do not offer a great advantage. One of the mechanisms, postulated is about how oscillations in the brain and functional networks have a significant interplay, and that might result in cognitive and negative symptoms. And in this context, the GABAergic interneurons of the brain and their dysfunction seems to be an important target. So because of this dysfunction, what might happen is that there is an aberrant gamma activity in the brain, and that leads to asynchrony and a network dysfunction, leading on to cognitive deficits and negative symptoms. And perhaps making the gamma activity all right might be one of the mechanisms by which negative symptoms and cognitive symptoms may be targeted. So this was one of the studies which is published examining the role of active TDCS against sham TDCS in a RCT design. What it looked at is the outcome of SAN score, the negative symptom score. After active stimulation, there was a significant reduction in the negative symptoms in this particular study when anode was used over left DLPFC and cathode over the right supraorbital. And there have been a few studies, and this has been meta-analyzed. And as you can see here, there seems to be an effect of TDCS over negative symptoms, as you can see in this graph. TDCS and cognition, it is getting recognized now with the same mechanism which I mentioned. There are some protocols going on, but overall, it might indicate that working memory might become better with TDCS and schizophrenia, whereas in other domains, there were non-significant results. And we examined the working memory performance with online TDCS and schizophrenia in a randomized double-blind sham-controlled, partial crossover study, and we found some interesting findings in the same direction as well. So overall, you can see that the primary benefit based upon the studies done so far has been in the field of auditory, in the area of auditory hallucinations and positive symptoms. Negative symptoms, there are some upcoming studies, and overall, it seems to be the effect of TDCS in schizophrenia. Now, there are multiple factors that might play a role when we do clinical studies with TDCS, because we don't study TDCS in medication naive population. We do study people who are already on an antipsychotic medication. So there could be an interplay, or there could be a mediating effect of the ongoing medications on TDCS. So one such interesting analysis was done by my colleague Mahavir. So what was done is that among the patients who we gave TDCS, we classified them based upon the Ka, or the dopamine affinity for D2 receptors, and classified them as group 1 and 2, group 3 being a combination, people are on a combination of both kinds of drugs. So significantly less improvement in auditory hallucination was noted in patients treated with antipsychotic medications having a really high affinity for D2 receptors, while those receiving medications like clozapine and having low affinity for D2 receptors, they seem to be improving. And similarly, some of the gene polymorphisms might also have an impact on the response to TDCS for AVH. And schizophrenia patients with COMT VAL homozygous genotype had a significantly greater reduction in auditory hallucinations than MET homozygous carriers in another analysis which was done. So I would like to conclude by saying that schizophrenia is associated with aberrant neural plasticity. There are clinical studies that offer support for utility of add-on TDCS in the treatment of persistent auditory hallucinations in schizophrenia. Personalized MRI-guided HT-TDCS has the potential to optimize the neuromodulatory protocols in schizophrenia. Now, what might be really required, like in the context of depression, right now there are a lot of studies which are happening in the context of depression, for instance, with multiple sites pooling in subjects, or harmonizing protocols across cohorts, looking at multi-center studies. So I think what is required now is larger number of participants in order to ascertain some of the findings, and concurrent evaluation of other symptoms and biological mechanisms that might help us establish the utility of TDCS amongst the important therapeutic avenues for schizophrenia. So it's quite early in the phase of research and clinical practice, but it looks like it is promising. I would like to place on record my gratitude to my team, particularly Professor Venkat, who's been leading our team, and most of our colleagues who have done the hard work, and the funding agencies who have granted, made this possible, made the studies possible. Thank you.
Thank you, Janardhanan. Can we go to the... Yeah, so maybe I can ask you just a question that came up from somebody, that we have all of these protocols which seem to be similar across, different different investigators or different teams. But how far are we from getting some kind of a specific uniform protocol for a specific condition in TDCS, just like we have protocols or standard operating procedures for other interventions in psychiatry? And what are the obstacles?
Okay. I think there are protocols in place, at least for some of the specific symptoms, like, for example, in schizophrenia. Auditory verbal hallucinations have been examined in a very consistent fashion by many research groups. But having said that, some of the targets, for example, in the treatment of negative symptoms, have an overlap with, say, depression. So I think carefully choosing the phenotype is really important. And I think, like I mentioned, there is a need for harmonization of the protocols across centers to examine this. So if you're looking at a specific disorder like schizophrenia, I think this particular paradigm for auditory verbal hallucinations and positive symptoms seems to be useful. But we really don't have protocols for the treatment of delusions, for instance. Even though there are some upcoming ideas regarding how midline TDCS might be useful for correction of alpha activity. So it is still nascent as far as the protocols are concerned. Am I audible?
Yes, please go on.
Yeah.
Can you stop sharing your slides? All right. Yeah, we are. Yes. So thank you, Dr. Janardhanan, for your lovely talk. Now we're going to have a small discussion on some general aspects which I thought might be relevant to the audience. So I'll be asking some questions to each of our speakers. If there are any more questions, you can put them on the chat box. First of all, I'd like to ask Professor Nietzsche, for example, a couple of people have asked, doesn't the larger size of electrodes affect the specificity of the area of brain that the TDCS is targeted towards? So is it, for example, beneficial or in any way more advantageous to use smaller electrodes, or would larger electrodes do just as well?
Yeah, I think this question was already nicely answered by Marom some time before. In my opinion, it really depends on the application, and maybe putting it to the extreme. So if you do basic studies in cognitive functions, then you want to be as specific as you can be based on the knowledge you have about the contribution of a specific area. And then you might be better off with smaller electrodes at the end. If for a specific function you do a pilot study and you're not so sure about an area, might still be not the worst thing to go with larger electrodes. But for example, this 4x1, you can also avoid the problem you have often in cognitive studies, that you have a second electrode with opposite polarity. If you think, for example, for attentional tasks or something like this, you won't be very happy with the return electrode. It's a frontopolar region, which might be also involved. So it's tricky to find an inert region, which then delivers you also current flow direction, which works for your target region. If you think about clinical applications, you might want to affect larger regions for different reasons. For example, for depression, I'm not so sure if affecting a smaller prefrontal region is really advantageous. With larger electrodes, you might also at least affect unihemispheric networks to a larger degree. Or another example in stroke, where you have remapping of areas also, and if you're not able to do in all of your subjects, all of your patients, MRI measures to explore where exactly representation area is, you might be also better off with a larger electrode, which gives you a better chance to affect specific areas. Another principal difference is might be also that, so due to results of our group, but I think also of others, is that if you have larger electrodes, you might, to a larger degree, not only meet your target area, but also afferent connections with your target area. So you have relatively long-range connectivity alterations with larger electrodes. And I'm not so sure if you get it to the same degree with smaller electrodes, at least for TACS. We did beta frequency stimulation study recently, where we saw relatively locally restricted of the stimulation with regard to oscillatory frequencies. But we need more systematic research there. But at the end, I would say it really depends on your optimal electrode configuration, including small or large electrodes. Depends on the kind of question you have.
Another question is that do you think that it might be better to have a symptom-based approach to choosing a protocol versus using a diagnosis-based approach? So, for instance, if you're dealing with, say, OCD, is it more useful to maybe look at what kind of symptomatology that a patient has, rather than using something like a diagnostic approach that already, if you have OCD, you do a specific thing for that?
Yeah. So in principle, I think that's a better way to go, because what we alter with neuromodulatory techniques, and this is not only restricted to TDCS, is functionality of certain regions, and so symptoms are closer to identification of regions than a disease. If you think about depression, this can come in very different shapes. If you think of schizophrenia, schizophrenia, I think it's a nice example where you have positive and negative symptoms, and the first studies were aiming primarily to modify hallucinations, and then more or less, I think as a side effect, they saw also reduction of negative symptoms due to the return electrode placed at, or the second electrode placed at the prefrontal cortex. Now there are coming up studies showing that prefrontal stimulation without this parietal electrode to modify hallucinations works also nicely on negative symptoms. So I think symptom-based approach makes absolute sense.
And finally, where do you think this field is going? I mean, you are credited with kind of being one of the, the initial people working in this area. You've been in this area for the last almost 20 years now, maybe more. So if you if you kind of gazed into a crystal ball, where do you see it maybe 10, 15, 20 years from now?
So I think the stimulation techniques will have their place still also in 20 years in basic research, because we are tackling basic physiological mechanisms. So exploration of the causal contribution of specific areas or networks or for specific function will still be there. And would be still relevant. There will be other techniques emerging. We have with magnetic but also electrical stimulation always a problem that we cannot be specific for deeper areas. For example, might be the case that ultrasound stimulation or specific new stimulation protocols gives you new approaches there to be to conduct specific stimulation also of deeper lying areas. There will be a connection, I think, with closer connection with functional imaging approaches also, which is important. So beyond the studies just showing behavioral changes, to have a combination of behavior and physiological changes, which will enhance also knowledge we gain about the physiological basis of psychological and behavioral functions. So that's for basic research. For clinical research, I think what we really need is to explore more systematically what kind of interventions gives us reliable and also larger clinical effects. Lots of pilot studies, which gives you always high impacts in journals showing proof of principle that something might work. But then the secondary step, it's a more laborious to identify really standard and optimized protocols. And this is something which is important for future. And so if you look at RTMS, for example, for antidepressant treatments, so in this study, which was crucial for FDA approval, they needed about 6 weeks of stimulation, 5 days a week to get significant effects versus the sham stimulation condition. There are rarely TDCS studies done which work over such extended timelines. Optimizing of protocols might make the needed timeline a bit shorter. But this is important, I think, to put things into clinical practice. And the second thing is also so individualization is a big topic currently. And this will tackle also the combination of different therapies. So, for example, the field of psychiatry, combining stimulation with psychotherapy, or also combining of stimulation with pharmacological interventions, which have been done in some studies, which makes sense. But we need also to learn more about the determinants of the individual reactivity to stimulation. And there things are going on. Studies are conducted to learn more about this. I showed you something about aging, and I showed you something about chronotypes. Modeling likely will play a role, but will improve also, I think. So currently we have a bit of heterogeneity, but the principle, nice models, but I think models need also to be improved, and it might make sense also to think about enriching of physical models with physiological modeling, because electrical field alone does not 100% predict what effects you get. This depends also on the activity of the neurons. This depends on electrical field to neuron orientation. So there are lots of things still to do. Yeah, I think we won't get bored in the next years. Things will become more complex. Maybe for clinical applications, what is also important to keep in mind, that things are getting not too complex. So we have a relatively easily to be applied techniques. If you need very complicated calculations and lots of diagnostic procedures before applications, it might make things non-feasible as compared, for example, with drug treatment and so on. So it's always a kind of balance, I think. So let's see, but we won't get bored.
Yeah, thank you. Professor Bixham, if I could ask you a couple of questions. Do you think that TDCS could be used in prevention and promotion of, mental health? Somebody just asked Anish, in fact, there is some evidence to suggest that, TDCS, for instance, is beneficial in learning or picking up a new skill or language or whatever. So do you think that there is a possibility that it might be used in a large way in non-diseased or non-morbid populations as well?
I think that's a very interesting question about the, people will often talk about the wellness applications of TDCS. So this is pre-clinical diagnosis. And people also talk about the consumer applications of TDCS, right? So these are people who would be using TDCS for different forms of enhancement. There's not a simple answer to your question. It has different dimensions. One of them, of course, is the basic question of will it even work for these different things? And obviously there's been a lot of literature looking at things like that. Things are called like accelerated learning, looking at the effects of stimulation on memory and other cognitive function in healthy individuals. So there are creativity. So there is a literature out there that I think has inspired people to think about these applications for these consumer applications. These experiments tend to be run under very controlled and limited laboratory environments. And so there's always a question of whether these results will generalize. So there's the scientific questions, and then of course there's the ethical and regulatory ones, which are I think also being debated and being discussed. And so the question, really the central question there is, should the government restrict access, right? That's really what it comes down to, or somehow regulate access to these devices. That's really the question, right? Should companies be restricted in their activities, and should individuals be restricted in their activities as far as what is available? And so I think that's the other dimension to it. It gets into issues that go well beyond.
Yeah, I can understand it. It's a very involved question, but I just wanted to have just a glimpse of what you were thinking about it. Do you think there is some degree of skepticism regarding the effectiveness of TDCS? Somebody just asked, it's been around for some time. Why is it maybe not as say popular as say ECT, which is very commonly used in many parts of the world? So do you think that there is some problem with regards to acceptability or the acceptability from the perspective of the clinicians with regards to TDCS?
I think my colleagues here on the panel who are clinicians would be more qualified to answer that question as me. One thing I can say from a scientific and engineering perspective is there has been more basic science and clinical neurophysiology, animal studies done on TDCS than many other techniques that are much more popular. Right, and so there's a contrast there with a very large volume of mechanistic data, a very large volume of engineering optimization, which by the way is also investigator initiated, right? This is not company sponsored. So any concern, if there was one about bias, is not there. These are investigator initiated trials showing strong signals in many different directions. And so I would push back on the notion that there's if TDCS is not as broadly available as we would like it to be, it's certainly not because of the lack of science. In fact, Dr. Nietzsche's foundational work wasn't a clinical trial. It was a neurophysiology trial. The basis of the field is in science. And so maybe I know if the other people on the panel have thoughts about it.
That TDCS reflects a kind of a translation of a demonstration of a physiological phenomena into a clinical application. So I think that's interesting. Just a couple of more questions that are directed towards you. Why did you use a percutaneous electrode for the Sotrix electrode detox? If you could just answer that briefly in case you want to take that.
That technology is an FDA cleared technology, and the technology that was used in the underlying clinical trials was percutaneous. So this was needle electrodes that would be inserted into the ear. And that technology itself has been around for a very long time. But of course, the question is, could it be done entirely non-invasively? So for example, the trial I alluded to that we're currently doing for neuroCOVID is transcutaneous entirely. I think that is an open question. Obviously, percutaneous induces a burden. You have to come in, the needles have to be inserted, and then they're walking around for a long time, with the stuff taped onto their ear. So of course, there's an advantage of whether you can do it transcutaneously or not. In principle, you should be able to. So I think that is I would say that for me, that's an open question about when do you need a percutaneous and when can you get away with a true wearable clip-on.
All right. Just the last question for you is TDCS, does it have comparable plasticity effects with regards to as compared to VNS or vagal nerve stimulation?
I'm not an expert on the plasticity effects of vagal nerve stimulation. I would say that direct current stimulation we know is a powerful modulator of ongoing plasticity. In our experience, it doesn't necessarily generate plasticity on its own. It modulates ongoing plasticity. So going back to your question, whether this could be used to enhance training, enhance learning, or enhance cognitive behavioral therapy, enhance other forms of therapy, there's a strong substrate for TDCS being used to enhance ongoing brain plasticity produced by other interventions. I would say in general, when I look across these forms of non-invasive neuromodulation, I can't see it as really competitive. When we have so much suffering and so much unaddressed need, I think wherever we can deploy these technologies with efficacy, great. We're not at the stage yet where we've solved depression, and now we can talk about which one is the better, approach. I think right now there's just so much uncharted space for all these indications, and so much potential.
Thank you, Professor Bixen. And I'll just ask a couple of questions from Anirban. So somebody just asked me, you using cerebellar electrodes, and is it possible that because the electrodes are so close to each other, they just shunts across through the skin or something? I understand that you're using FNERs to show that it's making a difference, but is there any way to kind of negate that or minimize that kind of shunting and ensure that you're getting the right effect?
Yeah, so I think so our electrodes for cerebellum are much further away from, let's say, compared to DLPFC electrodes, for example. So they are basically large electrodes placed on F3, F4, and the distance between them is much shorter than when we place it like PO9H, PO10H, which are like near ears. And these are like small electrodes of 1 centimeter. So I think it's not shorting for sure. And of course, the modeling shows that we do reach the cerebellum. May not be the whole cerebellum, but primarily the aspect of cerebellum near to the scalp, which is cruise 1, cruise 2 of the cerebellum. And those are essentially our targets also for the cognitive aspect of the effects. So I think in that way, they are related. Now, the question is more, I think, in terms of what we're seeing with FNIRS. So there is one challenge with FNIRS that I should mention is that there is, so the FNIRS signal not just measures the cortical activation or the brain activation, but also the scalp. So it has the systemic artifact. Now, there are ways to remove the systemic artifact, for example, with a shorter short separation channel. So it's basically a source and a detector. And if you actually move them close to each other, then you get primarily the systemic artifacts, which is from the scalp. And then if you actually move them away from each other, like 3.5 centimeter, then you go more to the brain. So we did that. So the recent work that we did is in healthy, where we showed that we do see the same kind of response that we have seen with in the stroke study, where we did not use that short separation channel. So it's indeed, there is an effect. However, this has to be looked much more carefully. And I think what we kind of depend on is the fMRI studies. And in fMRI studies, it's being shown, not just fMRI, but also with ASL studies that have been shown that there is a robust response in terms of hemodynamics. Now, the reason for the response, like Professor Bixen mentioned, is unknown. So it may be partly neurovascular coupling, which is from neuron to the vessel, or it may also be directly an effect on the vessel. However, I should mention that when we stimulate the cerebellum, the electric field at the prefrontal cortex region is like really low. It's like less than 0.1 volt per meter. So, I mean, not just 0.1, but 0.01 volt per meter. So, so I think the electric field is not reaching the prefrontal cortex. So it is most likely the connectivity from the cerebellum to the prefrontal cortex. But that's currently a working hypothesis in our case.
Okay, thank you. Janardhanan, I have a question for you. So what are the contraindications that you look for in patients that you take up for TDCs?
There are no, absolute contraindications per se. And generally, what is recommended is to look at the scalp and see if there are local lesions. It's important. These are the basic things that one has to look at. And then generally, metallic implants, etc., are generally important to understand. Otherwise, the absolute contraindications are quite minimal. Even say, for instance, epilepsy also is not considered to be an absolute contraindication for TDCS, considering the fact that it only produces resting membrane changes and not an action potential.
What about handedness? How much do you control for handedness?
In the studies that we have done, all subjects, at least the schizophrenia studies that we have done, all the subjects were right-handed. We chose people exclusively right-handed individuals, so that way it was controlled for. It might be an important aspect to look at, especially in conditions like schizophrenia, wherein the dominance of the brain plays a significant role as far as the language goes, and the lateralization of symptoms goes.
Yeah, because I think in some of the protocols that I've seen, most of the protocols are, or at least most of the studies are done in right-handed people. So it's sometimes difficult to kind of translate it into, whether you use the same protocol or you use the other side of the head for left-handed people. So it becomes a bit of a confusion, especially if you're, running a research project and you want to get as many people as possible. And then you have to exclude, say, left-handed people versus right-handed people. So yeah, so that is a problem. Maybe Professor Nietzsche would want to say something about that.
I would also say that it depends on the stage of the study you're conducting. So if you do a pilot with a restricted number of subjects first, you want somehow to have also some kind of optimal conditions. So this refers to handedness. This might refer also to the medications they take. You showed nice data that the kind of neuroleptic medication plays a role on the efficiency of the stimulation. And we know this also from basic studies. If you do your clinical study, then of course, another important question emerges. So if you've shown proof of principle, the question would be, does this really then apply to all kinds of patients? And so you're aiming for larger numbers of patients then to make sense of this study. And of course, you don't want to have completely uncontrolled variability, but handedness is one point. As also maybe similar to medication, that it would be completely unrealistic if you do a real clinical trial and then have only right-handed people with a specific kind of, let's say, neuroleptic medication. What you can do is increase the number, document, and then you can do post-hoc sub-analysis, which will tell you something about propensity to see clinical effects dependent on these conditions, which will then, if there are differences, give you also ideas how to go on. So, for example, for the neuroleptics, if the typical ones, the classical ones, cause you problems, this might be a question of stimulation intensity. This might be a question of maybe adding other medications with wait out some of the effects of classic neuroleptics you don't want to have, or where they are restricted. So there are some options, but this will be informative. And so I would be, if you have the option, and I think if you talk countries, clinical studies are always tricky in Europe and I think also in the US to get a sufficient number of patients. And I think that's not as problematic in some other countries, including India. And if you have the option to get larger groups of patients, then you can really systematically explore which factors cause better or worse efficiency of the stimulation techniques. And this will be a great thing and will bring the field really forward.
Right. I can think of many more questions, but I think we are running short of time. We've already overshot by around half an hour. Yeah, it's pretty late out here. So, it's been a personally enriching experience for me. It's been lovely having all of you, and I just need to read out some names. So I would like to thank all the members of the audience who came here and asked, took out these 2 to 3 hours and listened to these stalwarts. It's been wonderful having them. These speakers, they have been so generous with their time and out of their busy schedules, especially on a weekend. So truly blessed to have them. I'd like to thank the members of the Physical Treatment Subcommittee of the IPS, Dr. Nandkumar, Urvaksh, Sumitra Ghosh, Bhavesh Lakdawala. They have all been pillars of support. I couldn't have done it without them. I would like to express my thanks to IPS and Neuromodulation Society India, the Department of Psychiatry, PGI, from which I am, my colleagues and my students. I would also like to thank Professor Ajit Avasti and Professor S.K. Mattu, who have retired now, but it's because of their foresightedness that we started neuromodulation in the department. The Department of Telemedicine, PGI MER, for generously allowing use of their premises and equipment on a Saturday evening. Dr. Srinivas Balachandar, he's there. I wish he would switch on his video and wave to all of us if he can. Dr. Sanjana Kadiravan, junior resident, she's doing a thesis. Just come here and say hello to everyone. She's been there since the beginning, and she's been designing all the brochures and all the stuff that you've seen on the website. Thank you. Mr. Pankaj Pant, Associate Consultant from Telemedicine, for making all of this possible. He's been here on a Saturday evening. Say hello to him as well. And he's been doing a lot of stuff. And all his technological wizardry. Thank you very much. And we are passing through a severe phase of COVID-19. We touched upon that. I hope all of you safety and good health and good luck. And thank you for giving us all this opportunity to get to you. And it's been wonderful. It's been a lovely experience. Thank you so much. Thank you.